All right. Thank you for joining the live Multiple Sclerosis 2023 at the Frontier and Beyond conference. Before we get started, I'm going to share some information about the conference that you'll want to keep in mind. Next slide, please. So we're going to try to stick to as much as we can to the agenda. We may have to delay or start things a little bit later and or earlier, depending on how things go, because it is a live program. There's a couple breaks to keep in mind, one at 10:10 and one at 12:10. And then we have the Q&A panel at 12:30. Next slide, please. So if you have any technical issues, whether it be with the main meeting or any of the WebEx links for the exhibitors, you can give me a email, and or if you have any questions, and I can route you to our EdCom staff that will help resolve the issues. Next slide, please. So for the Q&A panel that's at the end of the program or near the conclusion of the program, you can ask questions of the speakers. And so you can ask questions about the topics that you've just had, or if you have other questions specific to MS. It's a good opportunity. Email me, Dawn, at chris.ohsu.edu. And this information will also be in our participant emails that you would have received. And if you have a particular question for a speaker, if you wouldn't mind just putting their name in the subject and question, I'd appreciate it. And we'll answer all the questions at 12:30 at the Q&A panel. Next slide, please. And again, at the breaks, we will be having virtual exhibitors. And so we have the National MS Society, GENENTECH, BRISTOL-Myers Squibb, BIOGEN, and PONS, which is also HELIUS Medical. And so we encourage people to visit the exhibitors at the breaks. Each one has a separate link, and the exhibits are live as far as people there from the different organizations and companies. And your information will be in the YouTube description, the links, as well as the email that you would have received, exhibits and drawings. Next slide, please. So one of the fun things that we're bringing back is if you visit exhibitors, we have a OHSU drawing that we're doing where you can actually receive a code word for visiting exhibitors and send the information back to me to be able to be entered into a drawing. And so we have an iPad, earbuds, mugs, kind of fun things. So visit an exhibit, receive a code word. After the conference ends, email me, chris.ohsu.edu, the code words that you'll receive in the meetings and will be entered into a drawing. Next slide, please. And so without further ado, I'm going to introduce Dr. Vijay Sri Yadav. She's a professor of neurology at OHSU. She's the director of the fellowship program and the MS Center. She's a staff neurologist and researcher at the Portland VA Healthcare System and faculty. She does research with the Department of Veterans Affairs, National MS Society, NIH, and PCORI. Her research interests include novel therapies and complementary treatment options for MS, which includes dietary and lifestyle changes, vascular risk factors, antioxidants such as lipoic acid and MitoQ, and stem cell transplant. So please welcome Dr. Yadav.
Thank you, Dawn. Thank you for the introduction. Can we go to the next slide? So good morning, everybody, and welcome to the program. This is the annual program that we do for our patients to give information about the latest that is happening in the field of MS and immunology. And also this year actually is a very special year for us, and we have a very special guest who will be joining right after me to celebrate the 40th anniversary of the foundation of the MS Center. So we are very excited to have this program today for you live. Next. Next. Just briefly about the MS Center, it was founded in 1983, and the current number of people that we follow in our clinics is more than 1,500 people. We have a pretty robust program with solid affiliations with the Department of Veterans Affairs, MS Center of Excellence. We are a member of the Consortium of MS Centers. We work closely with the National MS Society, and also close association with foundation or private foundations such as Raise to Raise MS. Next. As you know, MS is a complex disease, requires a lot of multidisciplinary care. We have at OHSU very proud to have this comprehensive care that we're able to provide and work with multitude of specialties that includes anywhere from the drug, the infusion and pharmacy related services that we have. Ophthalmology, for example, eye problems can be a symptom of MS. We have close association with radiology because, as you know, MRI is a really valuable tool for not only diagnosing MS but also following MS. People have symptoms that they are bothered by. For example, bladder issues. We have close association with urology. Other symptoms such as pain, spasticity, rehab issues that our people need, mental health issues that our people have, or sleep issues. All of these things we have specialized services available at OHSU, and we are very big on the overall wellness of the patients. So OHSU has this wonderful facility called March Wellness, and anybody is able to access these facilities. Next. We have close association with the VA MS Centers of Excellence. Most of our faculty have joint appointment with the VA, and that gives us opportunity to work with veterans at a very kind of high level. We do research in conjunction with the VA Centers of Excellence as well. So very valuable resource for the MS Center. Next. This is our current faculty. We are very proud to have a wonderful faculty. Majority of them are fellowship trained, MS fellowship trained, and quite a few of, as I will talk about in my research presentation, quite a few of them are involved in research, clinical research at the center. Next slide. In addition to the faculty, we have a very robust and thriving fellowship program where we train the neurologist into the field of MS and neuroimmunology. Currently, we have 5 wonderful fellows, and 3 of them are graduating. Actually, today is a graduation ceremony tonight, and then we'll have 2 more who will be joining us starting next month. So we really take pride in teaching the next generation of clinicians as well as clinician scientists in the field of MS and neuroimmunology. Next. Our staff, very proud of them as well, working very hard to keep the center running and helping all of you, the patients, and the program that we do here. So Annie Chen is our pharmacist. Christine Perry and Nicole, they are sort of the backbone of our center. Christine will be retiring. Actually next week she'll be retiring. So just wanted to thank her for her contribution to the center as well. And we will have a new person joining in her place starting in 2 weeks. Very robust research staff, and I'll talk more about that in my research presentation. Very proud of our education coordinator, Dawn, who's putting this program together, always helpful in getting any ideas that we have to educate the patients or providers. She's there to help us with her full capacity. And fellowship coordination is done by Jamie Henry. Very proud of her work as well. Next slide. So with that, I do not want to take the time from Dr. Bodette's presentation because I myself am looking forward to hearing him. Sorry, can we get to the slide again? So Dr. Bodette, it's my pleasure to introduce. It's a pleasure to introduce you. You've been my mentor. You've been mentors of so many people, so many clinician scientists over the years that I just don't have words to describe like your contribution to the field of not only training us, but also the entire field of MS. So I really want you to take over and, give us some insight and some words of wisdom on the 40th year celebration of the center.
Thank you, Vijay. Let's see if I can take over the slides. First, we have to start with the first one. Yeah. So that isn't the first slide, though. This is why that's at the start of my talk. That should be okay. Um, EdCom.
So we are not seeing the slides, Don. We are seeing your, you know. So can we get the slides, please, for Dr. Burdette?
Sorry, is that the right one?
I don't know.
I think this is the first one.
And do I have control of that?
Go ahead and take control now. Okay, you have control.
I'm sorry, the first set of slides were about
Sorry,
the
is this
state
not
of
okay,
MS.
stand by.
not-
All right, please release the control so I can switch.
Oh. It's released. It's that very first one that says MS 1983. There's like 3 slides before this.
Oh, is there?
Yeah. There we go.
Okay.
Okay. Shall I take control now? So far.
Yeah, please do.
All right. Well, those of you on YouTube, thank you for bearing with me. I don't seem to have control though.
Yeah, you do have access to the control now.
I tell you what, I'm
should be
gonna
able to arrow.
I'm gonna stop controlling and just do next slides, okay? Okay. As Dr. Yadav indicated, this is the 30th anniversary of the OHSU MS Center. I'll talk a bit about that, but I wanted to start with a reflection on how things have changed since 1983, when we first started the MS clinic. So in 1983, it was very difficult to make a diagnosis of MS. And people typically would have symptoms for 5, 6, 7, 8 years or even longer before they finally received a proper diagnosis of their illness. And we, of course, would take histories and do neurologic examinations. But in terms of additional diagnostic tests, we were pretty limited. We could do head CT scans, but they don't show the MS lesions very well. We would do a test that was called a myelogram, where dye would be injected into the spinal fluid, and people would be moved around so you could image whether there was anything pressing in on the spinal cord. It didn't show you the MS lesions, but it ruled out tumors or other things that could be causing MS-like symptoms. We could do something called evoked potentials, which would give us an additional way to look at electrical functions. And we do spinal fluid examinations looking at for certain abnormalities. And that was it. Importantly, treatment was quite limited. We could use steroids for relapses. There were symptomatic therapies to deal with bladder problems or spasticity or other symptoms. And we did early on begin to recommend that patients address their diet, get involved with exercise, and look at managing stress. And we could be very sympathetic, but that was it in terms of treatment. And As a consequence, people with MS at that time often became disabled within a few years. And in fact, it was well over 50% would become limited in their ability to walk within 10 years of the diagnosis. So that was a difficult time for people with MS. And as a physician, it was always challenging counseling patients. Next slide. So 40 years later, things have really changed dramatically. The diagnosis can be made much earlier. In fact, we have the capacity to make the diagnosis at the time of first symptoms. And it's more easily done. Patients don't have to undergo, for instance, the myelograms, which were quite uncomfortable. And the big change that occurred in terms of making the diagnosis, besides our increasing knowledge of the illness, that was the availability of MRI scans that allowed us to visualize the brain and the spinal cord and rule out conditions that could mimic MS, and also allowed us to directly see the MS lesions. We still do spinal fluid examinations, but less frequently than we did formerly, and that's still useful in terms of making an early diagnosis. Most exciting thing, of course, is that instead of having no therapies to offer patients to control their MS, we have 9 classes of therapies. Classes meaning types of drugs that work through different mechanisms. And there are 21 different FDA-approved drugs for the treatment of MS. Almost all of them being just for relapsing MS. And these therapies are highly effective at preventing relapses, preventing new MS lesions forming in the brain and the spinal cord, and have transformed the lives of many, many people with MS and transformed the whole field of MS. We use those therapies commonly in people, particularly those with relapsing MS. And we also still use steroids for severe relapses. We still use symptomatic therapies. And as Dr. Yadav discussed, we still advocate diet, exercise, and stress management. As a consequence of this change in therapy, many people with MS do extremely well over the long term. It was a completely different situation than it was 40 years ago. Next slide. As we're thinking about the next 40 years, what do we anticipate seeing over the coming years? Well, there'll be more therapies for MS becoming available, particularly for relapsing MS, and hopefully they'll be easier to administer and perhaps have more enduring responses. I believe that we'll begin to see therapies that halt or prevent progressive MS from occurring. I believe we'll also be seeing therapies that promote repair. And I believe that there's going to be more blood tests available to help with the diagnosis, the prognosis, and monitoring people on therapy. It's even possible that we may see at some point the development of a vaccine that could completely prevent MS and eradicate it. But surely we're going to see continued changes in the treatment of MS. Next slide. Now I wanted to talk about a little history of the MS Center. We started the center in 1983. Now, we was me and one nurse, so it was a small operation to begin with. But we grew the program progressively. At that time, we started the center with the idea of creating a place that would provide state-of-the-art diagnosis and treatment for people with MS, that it would serve as a place to conduct MS research, and ultimately we wanted to be able to train the next generation of MS specialists. As I mentioned, when we first started at the end of 1983, I was the only physician. A nurse helped out part-time, but we pretty rapidly increased the size of the staff. Next slide. So this is a photograph from 1985, just 2 years after the first MS clinic started, and it shows two other neurologists, Dr. Whittam, who's standing to my right, and Dr. Michelle Mass, who's two people over from my left. We also had a wonderful nurse that joined us, Bernie Perry, that's standing to my immediate left. And we had brought on board other people, a nurse practitioner, a social worker, research assistants, and additional nurses to help with infusions. And we did all of that within a short period of time. Now, since then, we've had some staff retire. So I retired, Dr. Whittam and Dr. Mass, all three of the physicians here have retired, but we've added other physicians, as Dr. Yadav showed, grew the staff, grew the program, extended the activities, and Dr. Yadav outlined the many aspects of the MS Center that have come into being over the years. So next slide. This shows a photo that was taken a few years ago, showing a number of the staff. Not everybody that was on staff at that time is there. Next slide. Here's another one. So many people, they had to crowd together around me. And next slide. I wanted just to touch on the MS research, since that was one of the reasons we created the center. Now, since the foundation of the MS Center, all the various people involved with research, whether it was in the clinic or in laboratories, have published well over 1,000 papers on MS in highly respected journals. So the OHSU MS Center has an international reputation for much of its work. We've created a number of new treatments that went into various stages of study. This included the T-cell receptor peptide vaccination, a novel therapy called RTL-1000. We identified mitochondria as an important target for treatment. We did a lot of work in my lab, then Dr. Yadav, and then Dr. Spain on lipoic acid, and that's led to a multi-center trial of lipoic acid for secondary progressive MS that's nearing completion. And we invented a remyelination drug that's been licensed to a biotechnology company. So a lot of novel approaches that were developed through our research. Dr. Yadav has been a leader in a nationally recognized leader in research on diet for MS. We are also doing studies on exercise in MS. And we've participated in a number of the multi-center trials that developed drugs that have gone on to be FDA approved, including Avodex, Betaseron, Copaxone, and Natalizumab, and are currently involved in the multi-center trial of stem cell transplant for MS. And finally, we've been involved with advanced MRI research that has led to novel insights into the disease. Next slide. I'm going to reiterate something Dr. Yadav talked about. Is a number of years ago, we started training young neurologists and how to be MS specialists. And this is every year we have typically 2 new fellows, and typically they do 2-year fellowships, although a few have done just 1-year fellowships. These are 2 different years, and looks like they're having more fun than they should. Next slide. I wanted to point out that our MS fellows have gone on to provide care to MS patients at various places in the country. Former fellows that we trained are now directors of MS programs at the University of Vermont, the University of Cincinnati, Louisiana State University in New Orleans, and Dr. Yadav was one of our fellows who's now the director of the MS program at OHSU. Others are involved with caring for people with MS at OHSU. Several of our faculty did their fellowships here at University of California, Davis, Ochsner Medical Center, New Orleans, Atlanta Neuroscience Institute, Providence, Portland, Bend, Oregon, and we even have a trainee in Saudi Arabia. So our fellows have gone on to continue to care for people with MS, many of them at prestigious academic programs. Next slide. This is a photo of Dr. Yadav and me with 5 of our fellows, 2 of whom are staying on for another year and 3 that are graduating. Next slide. And I wanted to finish with this slide. The painting is of Dr. Roy Swank, who for decades was the head of neurology at OHSU and did groundbreaking research in a variety of areas, but particularly in MS, and was the creator of the Swank low-fat diet, which many people still continue to follow, and was a real leader and in a field that few neurologists had an interest in for many years, but is now being broadly applied and studied for MS. I was a director of the MS Center for many years, but was very happy and pleased that Dr. Yadav took over the reins and the leadership of the center. So that's this photograph shows the continuity of MS leadership and novel therapy, starting way back with Dr. Swank and extending to Dr. Yadav. And with that, I've done, and it's a great privilege to be here, and so happy with all the things that the MS Center are doing now.
Thank you, Dennis. Thank you so much for your perspective, and it is so humbling actually to be part of this journey myself, and also to see your perspective of what MS was like in 1983 when the center was founded, and now where we are. So I think at least MS, when the new diagnosis is made nowadays, it is not as gloomy diagnosis, and we are much more optimistic with all the things that we can do for our patients. So that's really truly humbling, and so much we have learned from the patients that how to take better care of them. So thank you to the patients also for their support all along. So I think with that, what I would do is we'll move on to the next section, next segment of the presentation. I want to welcome everybody once again. I think we have probably more than 100 people who have joined us right now. And I just want to give you perspective of last year. We had people joining us from more than 45 states across the US, and more than 3 countries from around the world. So we are very thankful for the audience joining from all over the globe. And I would now like to introduce our first speaker, who has been trained under our program. Very proud of her, Dr. Maria Zhang. Dr. Zhang, she's an assistant professor of pediatrics and division of neurology at OHSU. She specializes in the caring for children with MS and neurological diseases, also general neurology disorders. She trained at University of Michigan Medical School and did her residency from the Vermont Health System in Michigan and child neurology from Louisiana State University Health Science Center. As I said, she did fellowship with us during actually the COVID pandemic. That was very unusual year, like 2020. And then she had joined us, and she was the first pediatric neurologist that we had trained. And I'm so proud of her that she has joined us. And not only she's a great clinician, but I think she's a wonderful researcher, and she could show that work within the 1 year that she was training under us. So I'm very proud that she's speaking to us today. And with that, I'm going to let her take the reign.
Thank you so much, Dr. Yada, for the really wonderful introduction. So while they're loading my slides, I just want to say that I am very excited to be here to talk about one of my favorite topics now. So the title of my talk today is Completing the Stress Cycle, Implications for Autoimmune Disorders and Living a Fulfilling Life. And I stumbled into this topic essentially through some personal suffering. I don't know what it's like living with an autoimmune disorder, but I do know what it's like living with a lot of stress for many years through the past decade because of medical training, and then a difficult battle with cancer in for my mother, and then eventually her death, and then me becoming a new parent immediately after. I really felt like I was kind of dealing with all these stresses adequately, and I was functioning okay. But at some point I began to develop kind of a variety of both mental and physical symptoms that initially I thought they were just kind of mysterious, but over time I realized they were actually long-term consequences of kind of chronic stress. You can advance the slide. So I had heard about this book that came out within the last few years called Burnout: The Secret to Unlocking the Stress Cycle by Dr. Emily Nagoski and her sister Amelia Nagoski. And in this book really was the first kind of publication that introduced me to the concept of a stress cycle. So the fact that, dealing with your day-to-day stressors of what's happening is actually separate from dealing with the effect of stress on the human body. And so that was a humbling kind of experience, because I had realized that, all those years I was mostly dealing with the stressors themselves and ignoring kind of the stresses on our body, or my body. And I had been talking about the importance of stress management for my patients for many years throughout all of my medical training and kind of early career. And then I realized that really I was pretty oblivious to stress on myself in my life. So that kind of led me to learn more about the physiologic kind of effects of stress and its implications on neuroimmunologic diseases. And now I am very passionate about talking about what I'd learned with both people in my own life and as well as my patients, to kind of help with both disease control and living a more meaningful and fulfilling life. Next slide. So I'll begin with this concept of the mind-body connection, and what does that really mean? So at its core, mind-body connection means that what the body experiences directly affects or what the mind experiences directly affects the body, and what the body experiences also directly affects your thoughts and emotions. Next slide. And the mind and the body are connected through the autonomic nervous system. And the autonomic nervous system kind of has two branches: the parasympathetic branch, as you can see kind of on the left side of the figure, That's to help with your body in its rest and digest mode, which includes kind of slowing down your heartbeat, decreasing your respiratory rate, and then stimulating your stomach and gut motility to help with digestion and absorbing nutrients, and then actually contracting your bladder to help you urinate. Then the other branch is the sympathetic nervous system, which gets you into the fight or flight mode. And that's when your pupils are dilated, you're scanning for threats, your heart rate increases, your respirations increase, your digestive system actually decreases. So you're not digesting, you're not really absorbing as much nutrients. And then your bladder actually expands and relaxes so you can store more urine, so you're not having to stop and urinate. Okay, next slide. Then the parasympathetic system, not only helps you rest and digest, but it's also the part of the autonomic nervous system that helps you kind of heal your body with tissue repair, as well as helping your immune system function kind of in the best that it can to fight off infections. Next slide. So it is hard to become aware of this connection because we're not really seeing or hearing the body and the mind talking to each other. But ultimately, just because we aren't consciously aware of what's going on, of this communication, doesn't mean that it doesn't exist or already affecting our lives. Next slide. So the goal of this talk is to increase awareness of how the mind and body connection affect health and autoimmunity, and understand how the mind-body connection can help us live in a more meaningful, empowered way. Next slide. In the specific kind of parts of the presentation will involve first defining the stress cycle, and then we'll go over kind of a brief overview of the data and research that have occurred over the past couple of decades on stress response and autoimmunity, and stress on multiple sclerosis, and finish the presentation going over some specific ways to process stress. Next slide. So a better definition of stress, we kind of lump it all together, but really the stress cycle emphasizes kind of three major components. One is the stressor, which is externally what's happened to you. Then you have the stress response, which is how your body is perceiving the stressor, and the physiologic cascade that happens when you elicit the stress response. Then lastly, in order to complete the cycle, you need to actually process the stress that has taken an effect on your body. And that's your kind of body's physiologic attempt to go back to the equilibrium state. And that's what we mean by completing the stress cycle. So the important thing to remember is that dealing with the stress itself is separate from dealing with the stressor. Next slide. And this is the stress cycle presented in kind of diagram form. You can see in the yellow, you have this, it starts off with the stressor, then your body is immediately evaluating, is this a threat? And if it is, then it elicits the sympathetic nervous system response, this kind of the physiologic stress response that we'll go over in more detail. And then that's when you have the physiologic effects occurring. And then finally, when this threat is considered to be over, your body, tries to activate the parasympathetic nervous system and resets to a calm state. And, I can give a couple of examples that may help illustrate this. So, historically, let's say thousands of years ago, a threat maybe to humans might be a wild animal chasing you, such as a lion. So that is the stressor, and your body immediately, categorizes it as a threat and elicits very quickly the stress response that gives you more energy, and then you're immediately you're fleeing, you're running away. And in this process, if the lion is suddenly struck by lightning and the lion, stops chasing you, the stressor is actually gone, but your body, you're left still with this kind of a lot of energy, a lot of kind of arousal. And you're not going to feel calm right away. So this is when, your body then tries to do certain things to get you back to the calm state, even though the stressor has been dealt with. And in the past, we're probably more intuitive in getting your body back to this state. You might run for a little bit longer to try to burn off some of this energy. And then you might find this in your family, your community, and kind of tell them about what happened. And then this kind of social connection is also a very important signal of safety to you in your body, that it's okay now to kind of reset to calm. And now, fast forward thousands of years, we no longer are routinely dealing with these kind of physical types of stressors. So a typical stressor now might be, you get a piece of mail and it's a bill that's much higher than, you thought it was going to be. And then now your body's interpreting this bill as a threat, and then eliciting the same kind of physiologic stress response that it did, many years ago in response to being, attacked. So now, you kind of figure out, okay, I have enough money, I can pay this bill. You pay the bill, the stressor is now gone, but your body is still left in this kind of activated stress state. So now, unless you're very kind of in tune and connected to how you're feeling, most people will assume that the stress is done, that they've dealt with it. But unfortunately, that's usually not the case. So unless you're doing intentional things to reset your system, you kind of risk going down the pathway of the long-term consequences of undealt stress. Next slide, please. So when we say, okay, we're eliciting the stress response, what we mean is, it starts off with the amygdala, which is an organ like in the deep parts, very primitive part of your brain, that kind of rapidly processes emotion. Most of the time, that's fear. And then it sends a distress signal to a command center in the brain called the hypothalamus, which is kind of directly above the amygdala. And the hypothalamus then communicates with the rest of the body through the autonomic nervous system and elicits the stress response, which is also called fight or flight. Next slide. And the stress response has two components. First is the fast response. And so this is where immediately your adrenal glands is producing the hormones norepinephrine and epinephrine, as well as the sympathetic nerves. And then they're dumping these two hormones into your bloodstream and increasing levels of norepinephrine in the brain itself. So both of these hormones then interact with the receptors of the autonomic nervous system in many bodily organs and does a variety of things. So it contracts your heart muscles, so you have a stronger heartbeat. Then it increases your blood pressure, your heart rate, your respiratory rate, increases blood flow to your muscles, increases blood sugar, so you have more immediate energy to use by your muscles. And then it also decreases the gut motility and digestion, decreases nutrient absorption. Also, at the same time, it's causing a lot of kind of mental behavioral activation. So you have enhanced this arousal, you're very alert, you're vigilant, you have focused attention, and then you have temporary pain relief. Next slide. And these changes are happening so rapidly that really you aren't aware that they're happening initially. The hypothalamus and amygdala are starting this cascade before the brain's visual centers have even processed the visual stimuli of what's happening. And this wiring is highly conserved in a lot of animals, meaning that most animals, especially mammals, have the same wiring to detect threat and have this response. And that's why people can jump out of the path of traffic before they can even consciously think about what they're doing. Next slide. Then, as this initial surge of the epinephrine, norepinephrine hormones are kind of coming down, the hypothalamus then activates the second part of the stress response if the brain continues to perceive a threat. And this is called the slow response. And that just ensures that the sympathetic nervous system keeps the gas pedal pressed down to keep your body activated. And this is done through the release of another hormone called CRH from the hypothalamus into the blood, which then stimulates stress-induced ACTH hormone produced in the pituitary gland, and ACTH then stimulates the adrenal gland to produce, what I'm sure you've all heard of the hormone cortisol. And cortisol tells your body to stay activated and on high alert. Next slide. Effects of cortisol, some of them are similar to epinephrine or epinephrine, which decreases functions that would be non-essential or harmful in a fight or flight situation. It changes your immune system. It suppresses the digestive system, suppresses reproductive system, as well as any growth that may be happening, especially if you're pediatric age. And then it's telling the brain centers, communicating with the centers that control mood, motivation, and fear. Next slide. So overall, this fight or flight response redistributes blood to the more primitive parts of the brain and the muscles. And so interestingly, it actually decreases activation of the higher functioning parts of the brain. So that's what we call the cortex. That's like the folds and kind of your brain that's really what humans are more known for, which is rational thinking, critical thinking. So when your stress response is activated, this part of the brain gets less blood flow, less energy, and you're just physiologically less able to think rationally when you're very scared or very angry. So the net effect of all these responses is that it allows someone to perform more strenuous activity than usual, and can be really helpful in times of kind of medical threat if your body is experiencing decreased blood sugar or hemorrhagic shock, if you need to kind of exercise beyond your typical anaerobic threshold, or if you're being suffocated. Then when the threat passes, your cortisol level is supposed to fall, and the parasympathetic nervous system puts the brakes on the stress response. So it's it's important to know that your body wants to get back to the pre-arousal levels, that's part of what it needs to do to restore the homeostasis kind of your two autonomic nervous system parts. Next slide. So in purple here, that's kind of the completion of the stress cycle. And now we'll kind of talk about some of the long-term consequences. Next slide. So when you have chronic activation of the stress response, kind of known as chronic stress, without opportunities to complete the stress cycle, that's when you have the disruption of the return to the non-stress state, and it leads to a dysregulated cortisol system, meaning that it's not really adhering to the same checks and balances or the same rules as when it's functioning more optimally. It's kind of going off the rails. So the long-term results, I'm sure you've all heard of some of these. So heart disease, chronic stress is a major cause of heart attacks, strokes, and high blood pressure. Stomach ulcers, sleep problems, cortisol, the hormone can affect both sleep quality and quantity. Psychiatric disorders, including symptoms of depression, and then immune system dysregulation. Next slide. But the tricky thing is that stressors and the stress response are not inherently bad because they're part of being alive. They're part of just what the human experience means, is being exposed to stressors and then your body automatically eliciting a stress response. But the parts that we can potentially change and control is then the process of the stress, to return to equilibrium. Next slide. So now we'll kind of go through some of the data on the relationship of stress and autoimmunity. So about half the time, the onset of a generic kind of any autoimmune disorder doesn't have a known trigger. So some epidemiologic studies have suggested that stress could be involved in both triggering and exacerbating autoimmune disorders. Many of the retrospective studies have found that most patients who have an autoimmune disorder report some form of kind of uncommon emotional stress before disease onset. For example, early life stress has been linked to the onset of type 1 diabetes, and stress in adults have been associated with both kind of the onset of lupus as well as exacerbation of lupus symptoms such as pain and sleep disturbances. About 70% of MS patients in one study had reported unusual amount of stress before the onset of MS. And there's been also a preliminary kind of study showing that an antidepressant medication also used for anxiety has been associated with decreased risk of MS relapses in women. But this is pretty preliminary study. It was not placebo controlled. And in the mouse models, the use of a sedative diazepam has been shown to decrease the incidence of experimental autoimmune encephalomyelitis, which is the mouse model kind of similar to multiple sclerosis. Next slide. In 2018, researchers retrospectively analyzed over 100,000 people who were diagnosed with a stress-related disorder. Most commonly were PTSD and adjustment disorder, and compared their tendency to develop an autoimmune disorder more than 1 year later with a similar number of their siblings who didn't have a stress-related disorder, and then another million unrelated people who also didn't have stress-related disorders. And they found that the people who were diagnosed with a stress-related disorder were more likely to be diagnosed with an autoimmune disease. The differences were, so it was 9 per 1,000 patient years in the group with stress-related disorders versus 6 and 6.5 per 1,000 patient years in the other two groups. And not only that, but those with a stress-related disorder were actually more likely to develop multiple autoimmune disorders. And these findings were generally just more pronounced in younger people, probably because younger people tend to have a more active immune system. And then in those with PTSD who were actively being treated with an antidepressant, anti-anxiety medication, that increase in the autoimmune disorder rate was actually less dramatic. This study, even though it included a large group of a lot of people, were still limited by surveillance bias, which is that the variation seen between the groups could have been due to just the different modes of detection versus a true difference. And then limited information about some other kind of unmeasured factors, so infections preceding autoimmune diseases or other medications that patients were taking. Next slide. And to kind of learn a little bit more about what might be the mechanism behind linking stress to autoimmunity. So stress has been linked to an increased systemic inflammation. A meta-analysis of several studies have shown that certain pro-inflammatory cytokines, such as, so cytokines are kind of the way that molecules that immune system cells produce to talk to each other. So these cytokines include IL-6, TNF-alpha, and IL-1 beta. So the secretion of these are increased in response to acute stress in humans. Then in rats who've been stressed because they've been deprived of their mother, they showed that there was also increased cytokine expression in the liver and the spleen, as well as a immune response against their own gut microbiome. Then in mice that had been stressed because of social disruption, they found that there was bacteria spread to places where there really shouldn't be any bacteria, and also had increased kind of circulating IL-6 and MCP1 levels, which are both kind of pro-inflammatory. Next slide. And so stress may increase inflammation throughout the body and brain through changes in the intestinal microbiota or the gut microbiome, because your gut is colonized by a variety of kind of microorganisms. So kind of changes in the microbiota have been described in patients with type 1 diabetes, lupus, and MS. Reduction of the diversity of the microbiome was shown kind of before the time of diabetes onset. And fecal transplantations of the gut microbiome from a diabetic mouse to a non-diabetic mouse has been shown to induce pancreatic inflammation. Then this acute psychological stress, such as public speaking, has been shown to trigger intestinal hyperpermeability, which is when the GI tract is absorbing kind of more than just the water and typical nutrients, because it's allowing more things in. So potentially could be letting in toxins, but still the role of this hyperpermeability in autoimmune disorders is still unclear, is whether it's a cause of it or just a symptom or an effect that's seen. Next slide. In people with MS, also changes in the microbiome has been found compared to healthy controls. But to date, we don't know of a particular microorganism or bacteria species that's involved. In MS, elevated kind of Th1 cells, which are T helper cells, and Th17 cell pro-inflammatory responses are observed in the intestinal lining and then the lymph nodes around intestines as well. They showed that after colonizing germ-free mice with a single type of bacteria that increases IL-17 levels in the gut, these mice then developed EAE, which is the mouse MS model. So this suggests that the microbiome can affect neurologic inflammation by recirculation of these Th17 kind of T helper cells to the brain, and that autoreactive T cells from the gut could migrate to different organs, such as the brain, to trigger something like MS. Next slide. So now moving on to more kind of human clinical data, looking at MS and stress. So first, I want to say that the studying stress and measuring stress are extremely challenging in research. There's basically, we don't have agreement on what is the best way to measure stress and what variables are important to control when looking at association between stress and MS relapses. Most studies that have been done use measures of how much stress is in the environment. So essentially, they're measuring the stressor. It's more external. Only a few studies have used either laboratory stress measures in the human body or psychological kind of stress of how much distress you're feeling. Next slide. So for looking at the relationship of stress and the risk of developing MS, there was a major meta-analysis published in 2011 that reviewed this association. Most studies that were included in this meta-analysis were case control studies. And while it did show an association between stress and the onset of MS, case control studies have problems with recall bias, which is just that people are not accurately remembering what happened in the past. And they all kind of assess stress during a time window that was pretty short, like 6 months prior to the onset of MS, and that just may not be representative enough. So because of this high variability on how stress was measured, the authors of this meta-analysis essentially said there's no kind of definitive conclusion could be drawn. Next slide. Since the publication of this meta-analysis, there hasn't been major studies published that have used significantly different methodology, but a 2018 study tried to clarify some of these prior inconclusive results. They included a much bigger patient population of over 500 people with MS and over 1,000 healthy controls, and assessed their stress kind of in a longer time frame, so within the 3 years prior to MS diagnosis. They found that the total number of life events was not associated with the risk of developing MS, but that specific life events were seen to be associated. And those were having had a homeless period increases your risk of developing MS by an odds ratio of 3.85. And then having had a divorce in the 3 years leading up to the diagnosis increased by an odds ratio of 2.1. Then the more the factors that were seen to be associated with reduced risk of MS included marriage and, interestingly, joblessness. So this study was limited, again, also by recall bias because it was all done kind of retrospectively looking at the past. Next slide. Then looking at stress and actual MS relapses in people who were already diagnosed with MS, there were two major studies in 2003. So one was a prospective observational study that found that self-reported stress was associated with doubling of the risk for relapse. In the same year, there was a longitudinal study where 50 female MS patients were followed for 1 year. And this was one of the few studies that actually included physiologic monitoring. So they gave these patients at the very beginning, all a standardized stressor, and then they measured their cardiovascular reactivity. So they measured stuff like their heart rate, blood pressure, and respiratory rate to have that be a marker of how much stress response their body is mounting to the stressor. And then they followed these patients with weekly life event questionnaires, and they found that relapses were 3.4 times more likely to occur in the 6 weeks after a stressor event was reported on the questionnaire. And each stressor event was associated with half week of sick time due to MS relapses. Then they also found that the baseline kind of cardiovascular reactivity that they measured in the beginning, so they found that if you had higher cardiovascular reactivity at that time, it was associated with a higher risk of MS relapses. Next slide. More recently, in 2022, last year, there was a study published examining the association of stress, anxiety, depression, and the risk of relapses during the COVID-19 pandemic. This study found that the annualized relapse rate was, so they calculated this rate retrospectively, both during 2019 before the pandemic and then 2020 at the beginning of the pandemic. And they found that in over 200 patients with relapsing MS, that the relapse rate was significantly increased. In 2020, it was 0.32 compared to 2019, 0.22. And after matching survey responses on their mood and stress and their incidence of relapse in 2020, they found that there was a significant association between relapses and stress, as well as relapses and depression. But in this study, they did not find association between relapses and anxiety or PTSD. And this study was limited by recall bias as well. And most of these patients actually were not getting MRIs because of the limitations of the pandemic. Next slide. Then last year, there was also a study published on the impact of pre-existing PTSD on MS relapses in veterans. So they included about 96 veterans with MS and a pre-existing PTSD before their MS diagnosis, and they matched this group with controls who did not have PTSD but also had MS. And they found that the mean annualized relapse rate was higher in the PTSD group versus controls. The difference, it was 0.23 versus 0.06. And the annualized mean number of new T2 lesions and gadolinium enhancing lesions on the brain MRI was also greater in the PTSD group. It was 0.52 versus 0.16, and then 0.29 versus 0.08. And then importantly, they found that the disability accrual time, so time to a specific disability scale score of 6, was faster in the PTSD group, 23.7 years versus 29.5 years in the non-PTSD group. This was the first study to show that PTSD could potentially be a modifiable risk factor for MS relapses, MRI activity, and disability. But of course, the study was done in a more kind of homogeneous population of veterans, so it needs replication in more diverse groups. And the study also had non-standard time points for MRI and clinic visits, which introduces additional kind of bias into the study. Next slide. So looking a little bit more on the relationship of stress and new lesions on MRI. So new lesions or enhancing lesions on MRI have been used as a more sensitive measure of disease activity as compared to just clinical relapses alone. And one study found that the risk of developing enhancing lesions or new or enlarging T2 lesions about 1 to 2 months after a major negative life event was increased with an odds ratio of 1.77. Whereas a positive, kind of a more exciting event had reduced this risk. Next slide. And for interventions to reduce stress in people with MS, there was a randomized controlled trial of a standardized kind of cognitive behavioral therapy program that was implemented and published in 2012. People with MS were randomized either to the therapy program or placed on a wait list. And all those enrolled had disease activity within the past year leading up to enrollment, and all stayed on their DMPs. They, the therapy group received 16 therapy sessions over a 6-month period, and then the patients were also followed for additional 6 months without therapy. And results showed that this intervention reduced stress, reduced the number of enhancing lesions on MRI. About 77% of the patients in the treatment group were free of lesions in that first 6-month period, compared to 55% on the wait list. But these differences, once therapy was stopped, they were not sustained at the end of the follow-up period. And then also showed that the group who did receive therapy had decreased brain atrophy, that they lost about 0.11% of brain parenchyma, whereas the control group lost 0.43%. Next slide. And then other modalities of kind of stress reduction has been examined pretty commonly in the past decade, actually. So this was a study that some of our own were involved in, Dr. Bordet and Dr. Yadav. And they had 119 people with MS complete questionnaires on mindfulness, stress, coping, resilience, and medical outcomes. They found that greater trait mindfulness was significantly associated with decreased psychological stress, better coping skills, and increased resilience, as well as a higher quality of life. After controlling for confounders, they found that mindfulness accounted for about 25% of the variation in perceived stress scores and 44% of the variation in resilience scores. So these results supported more investigations of mindfulness training to kind of increase psychological resilience and improve well-being with those with MS. Next slide. So a couple years ago, there was a meta-analysis that included 23 randomized controlled trials of mindfulness and acceptance-based interventions that were provided for people with MS exclusively. And they found large effects on reducing depressive symptoms, anxiety, stress at the immediate post-test and at the follow-up. And they found a moderate effect on reducing fatigue at the immediate post-test and at follow-up. And they found a large effect of reducing pain at the immediate follow-up, although they did not find the significant effect at the follow-up for pain specifically. Next slide. And this was a review of a slightly different form of stress reduction practice called this compaction practice, which we actually will go over towards the end of this talk. And this review included 15 studies, over 1,700 participants total. 8 were quantitative studies, 6 were mixed method, and 1 was just qualitative. And from the qualitative data, they concluded that people with MS kind of thought of compassion as involving self-kindness, agency, and acceptance. And people with MS reported using self-compassion in response to unpleasant sensations and experiences. And the quantitative data suggested that people with MS may become more compassionate over time through training in mindfulness, and that greater self-compassion correlated with less depression and fatigue, better resilience, and better quality of life. Next slide. Some other kind of interventions that have been published in patients with MS. Yoga, so specifically, this was called Love Your Brain Yoga. And they found significant improvements in fatigue, positive affect, and well-being in the people who did yoga. And participants were very satisfied, and the majority definitely wanted to recommend it to a family or a friend. Next slide. And then, kind of the study on just, stress reducing activities has been associated with reduced fatigue and depression in people with MS. Next slide. Currently, actually in Portland, there recently was a feasibility study on community Qigong, which is a mind-body practice. So I'm looking forward to actually Dr. Woolliscroft within our group was involved in one of the publications. So I'm definitely looking forward to kind of more studies on mind-body practices coming out of Portland in the future. Next slide. So finally, I want to go over some specific ways to complete the stress cycle to help activate your parasympathetic nervous system and reset to calm. Next slide. There are two main ways of processing stress. One is called top down and one is called bottom up. So top down just means that you are engaging, kind of going through your brain, your highly developed areas of processing information, the cognitive thinking areas of the brain, to then help change kind of your way of thinking, of like using logic, planning, problem solving, to then eventually trickle down to effects of the body. Then this is what most mental health services or psychotherapy use, helps us change our negative thoughts or kind of limiting beliefs. And it can be really helpful, but it has some limitations because it relies on a person's ability to become conscious of their thoughts and then work to change these thoughts. Next slide. Examples of top-down processing, so cognitive behavioral therapy, dialectical behavioral therapy, exposure therapy, psychoanalysis, and some others. Next slide. So sometimes top-down approaches are not enough because stress responses can happen before our higher cortex can even register what's happening. So because sensory, you have routine sensory input from the world is processed, again, by the most primitive parts of the brain, such as the amygdala. And these regions are processing information unconsciously and directing changes in your body before you've even had a chance to think about what's happening. And then it's already eliciting the stress response and triggering a variety of emotions and sensations, such as anxiety, sadness, anger, headaches, muscle tension, pain, and racing heartbeat. And when the stress response is elicited, you may remember rational thinking is actually limited because your higher cortex regions are just less activated. So we may have kind of automatic stress responses to past traumatic events triggered by something in the present without having even a clear memory of what happened in the past because you were too young or because you were, consciously kind of suppressing the memory. And so the neuronal pathways that were involved when you had an unprocessed kind of stressful traumatic event become sensitized. And that's how the body is holding on or remembering past trauma, is through these sensitized neuronal pathways that then can be re-triggered in the present without our analytical mind really knowing why. Next slide. So this is in the last, I would say, like half a decade or so, bottom-up processing has been kind of more talked about. And this is where you, instead of starting with the brain, you're starting with kind of the sensations and movements of the body to try to tap into some of these pathways. And some of the example are, somatic experiencing method, or EMDR, which is used in PTSD, yoga, art therapy, dance, movement therapy, and play therapy. Next slide. And you really don't have to be going to these kind of formal therapies in order to kind of tap into these pathways. So these are some of the most effective ways to complete the stress cycle, starting with mindful breathing. So breathing is actually one of the quickest ways to tell your autonomic nervous system to kind of bring on the parasympathetic nervous system, because it's a language that your body can understand, which it understands it a little bit better than just words. And then other things, so movement, creative expression, crying, laughter, and physical affection, and social connectivity. All of these sound very basic, but again, your body evolutionarily was wired to do all these things, and it doesn't change as quickly as our kind of world has changed. Next slide. And then, I'm not going to read all of this, but there are even more ways, very simple ways of activating the parasympathetic nervous system. Just getting enough sleep or taking a bath, being outside is really important. Cuddling a pet, or having your feet on the ground, feeling that sensation of grounding. Next slide. Finally, I'm going to end with compassion. So it's a practice that's a little bit different from everything we've talked about. And it also helps bring the body into the parasympathetic state during times of suffering specifically. Next slide. Self-compassion is more than just an idea. It has positive physiologic effects because when we soothe our own pain, we're tapping into our mammalian caregiving system and activating the vagus nerve and the parasympathetic nervous system, triggers the release of oxytocin, which in many ways is the opposite of all the stress hormones because oxytocin increases your feelings of safety and trust and connectivity. And it's released in a variety of kind of bonding situations between parents and young children or between each other when you're receiving kind of a tender hug. But you can actually direct this towards yourself, and it has kind of similar effects as if you had involved another human being. Next slide. The three components in brief are one, kind of self-kindness versus self-judgment, where this is where you acknowledge the suffering, but you're being kind of warm and understanding and instead of feeling judgmental about the suffering. Then you acknowledge that there's common humanity, that all humans suffer, and that this is part of a shared human experience that everyone goes through at some point. Finally, you have this mindfulness of this willingness to observe your negative thoughts and emotions with openness, as opposed to identifying that you are your negative thoughts. Next slide. And as part of it, there's a physical component, which is a soothing kind of physical touch to yourself. And that helps release oxytocin and decreases cortisol. Our body actually doesn't differentiate between touch provided by yourself versus someone else. So you can try kind of giving yourself a warm hug or putting your hand on your heart or kind of gently rocking your body. Next slide. Okay, I know we are out of time, but this is kind of a 3 to 4 minute long kind of guided self-compassion break. Kind of narrated by Kristen Neff, who is kind of the start researcher of all of the self-compassion. So I'd love for us to be able to finish with this if we can.
This is the version of the self-compassion break designed to bring in some tenderness, some loving, connected presence when you're hurting or struggling in some way. So please think of a situation in your life where you are in some need of some care. Maybe you're feeling inadequate in some way, feeling badly about a failure or a mistake you made or something about yourself you don't like. Or maybe something's very difficult in your life, stressful, challenging. So allow yourself to feel your way into the situation. What's going on? What are you feeling? And also feeling the distress in your body if you can, right? So dropping out of your head into your body, feeling the discomfort. And now we're going to bring in the three components of self-compassion, starting with mindfulness. So mindfulness, when it comes to tender acceptance, is really just about being present with what is. Right? Being present and validating the pain. So saying to yourself something like, this is really hard to feel this or to experience this. Right? This moment is painful. It's a moment of suffering. And also reminding yourself of your humanity. Right? Feelings like this, situations like this. This is part of being human. There's nothing wrong with me for feeling this way. And I'm certainly not the only one. So allowing yourself to feel your connectedness to others in your own imperfection. And then finally, we want to bring in some kindness. So one way to do that is with physical touch. So putting your hands on your heart, perhaps, or cradling your face with your hands, feeling the warmth of your hands. And saying something kind to yourself, which is exactly what you need to hear in this moment. Maybe it's a message of acceptance. It's okay to be imperfect. Or a message of support. You know, I'm here for you. It'll be okay. And if you aren't sure what to say, you might imagine what you would say to a dear friend in a very similar situation. What words of care and comforting would you use to help your friend? And then try saying something similar to yourself. Now letting the practice go, just allowing yourself to be exactly as you are in this moment. And if you're feeling any distress, you can always try grounding your feet in the floor, feeling the soles of your feet, feeling that stability.
Thank you so much, everyone.
The self-compassion break.
Okay,
This is a version of.
Yep, that's it. Thank you.
Thanks, Dr. Zhang. That was such a wonderful talk. Thank you so much for sharing with all of us and also teaching us, everyone, how we can really practice these kind of, these practices which seem very innocuous or very trivial, but they can have such a powerful impact. And I really want the audience to really think about the things that Dr. Zhang talked about in this in the presentation. And we'll have a Q&A session at the end. So if you want to send the questions to Dawn at the address that was sent to you in the email, we would definitely like to address many of those questions, if we can. So please keep the questions coming. And we are actually a little bit behind now, but that's okay because we will try to catch up and adjust the timing. So what I'll do, I will have Dawn come back and then sort of explain how the break will work. And then we'll have a very exciting next half of the presentation today. So Dawn, you can come over.
All right, we're going to go ahead and take a break, and we're going to actually come back a little bit later than previous. We were going to come back at 10:30, but we're going to come back at 10:40. And I just wanted to let you guys know that we have virtual exhibitors. The exhibit links are in the email that you've been sent, and also in the description of the YouTube channel. You'll see exhibit links for each of the exhibitors. We have the National MS Society, GENENTECH, BRISTOL Myers Squibb, BIOGEN, and HELIUS Medical, PONS. And there's representatives waiting for you to visit them now. And we're doing a fun thing with a drawing. So if you visit Exhibitors, they'll give you kind of their own code word, and you email that to me during the program or after the program, and I'll enter your name for a drawing for a chance to win an iPad or earbuds or another gift. So go ahead and take a break and stretch, visit Exhibitors, and we'll come back and see you at 10:40. Thank you.
So welcome everyone. We are back into the next segment of our session here. And I'm very pleased to announce our next speaker, welcome rather our next speaker, Jeff Schlimgen. Jeff is a physical therapist here at OHSU, and I think works primarily at the Center for Health and Healing, where we have had many, many interactions with him over the last, I think, more than 10 years now. And I think we would, I wanted him to talk on this forum, mostly to sort of talk about the latest in technology that we're using in the physical therapy and rehab aspects. So I'm very pleased that he's here to educate all of us about that. So just briefly about Jeff, he is a neurological certified specialist from the American Board of Physical Therapy Specialties. Did his PT degree or obtained his PT degree from University of Iowa, and has worked at OHSU for more than 15 years, and now currently supervises the entire physical therapy team. He not only works with the patients with multiple sclerosis, but also helps with other neurological diseases such as Parkinson's disease, people who have had concussion, and muscular dystrophy. So with that, I would like to welcome Jeff. Jeff, the floor is yours.
Thank you, Dr. Yadav. I appreciate you inviting me, and such a nice welcome, as well as such a nice presentation before me. That was really nice to see Dr. Shang's suggestions for stress and coping. All right, let me see if I can.
Yes.
Great. All right, so feel free to add any questions or comments in the chat as we go along here. I learn from my patients, and I would hope to learn just like I did from our previous presenters, from you guys as well. So feel free to jump in and throw in some comments and questions. I have no disclosures. I will be presenting many different technologies today. So I have some videos if they work properly, but I don't have any financial ties with any of these companies. So this is a way to look at how we might make an impact in physical therapy on disease. As Dr. Bordet pointed out earlier, drug therapies can often have a lasting impact and decreasing disability as 5, 10, 20 years down the road. And I have no doubt that that coping skills that Dr. Zhang so elegantly talked about, mindfulness as well as self-compassion, can all have an impact on disability later in life. So if you think about diseases like Parkinson's or cardiovascular disease, it's a very similar model where we want to have some early intervention and make an impact for years to come. And I hope our physical therapy skills are often making an impact too, not only short-term, but on the long-term effects of the disease and preventing disability. Go ahead. So I'm going to actually get to the bottom line of exercise. Exercise is one of my best tools as a physical therapist. Exercise, and I want to include physical activity, because it's not just about going to the gym. It's about having an appropriately active lifestyle. This is some guidance from the Canadian physical therapy guidance that had some wonderful guidance out of our neighbors to the north. 30 minutes of moderate intensity exercise, aerobic exercise, twice a week is the recommendation there, and then strength training twice a week. Now, if you're not doing any sort of aerobic exercise right now, it's not something you want to go out tomorrow and do 30 minutes of aerobic exercise. It would be something you want to gradually build up to. And what do we mean by moderate intensity? First of all, it just means that it doesn't have to be vigorous. Exercise people often think of as being a vigorous form. It doesn't have to be that way. Matter of fact, you would want to talk to your doctor before even thinking about vigorous exercise. Moderate exercise is safer. It's easier to do. The effort level, and we think about on a scale of 0 to 10, what is moderate exercise? I generally say 3 to 4 out of 10. The Canadian guidelines, I think, said something like 5 or 6 out of 10 effort. What you want to do is be listening to your body. You want to be listening to your voice. Can you be conversational with the exercise? can you still sing a song as you're exercising? If you can't sing a song, if you're getting short of breath, only able to get out a few words at a time, you're probably moving towards that vigorous side of aerobic exercise. So keep that in mind as you're thinking about exercise. This is a guideline that's looking mainly at mild to moderate people, severity of MS. So it doesn't address the severe MS. So there is another guideline out there that came out of the United States a couple years ago, and it makes an attempt to try to give people ideas on how to exercise with more severe MS. So, they do talk about mild to moderate MS, and that's that EDS score of 0 to 6.5. 150 minutes a week of exercise, and it can be physical activity too. It doesn't have to be just exercise. So we can count some of those minutes there. They threw out the number of 7,500 steps per day. I'm not exactly sure where that came from. It might be probably more realistic for somebody with mild MS, somebody with more moderate, and definitely with more advanced MS. That's not realistic, but it does give at least some specifics. The other notes, things to think about is that there are options. There's lots of options. You may need to be open to a different option than what you had done previously. If something is too intense or too vigorous, then you may need to go a plan B. It gives some really great options related to yoga, seated yoga or seated boxing even, for more active upper body movements. This really gives some great ideas for people. So the bottom line, we're saying 150 minutes per week of lifestyle physical activity or exercise. My other recommendations would be to seek some guidance from somebody familiar with MS to as you're starting something like this, or as you're modifying, if you're looking for ideas, as your body changes, certainly your body changes with the disease, and you have to have some coaching there. So setting a goal and sharing that with someone, that helps promote some accountability. Like that idea of social connectedness, really, as Dr. Zhang talked about, is use that powerful tool. Thinking about sustainability, this is not something you're going to do for a week or two. This is it's not like an injury that goes away in a few months. This is something that we want to think about engaging, enjoying, trying to find some joy in that physical activity. Again, moderate intensity, and being open to adjusting to a plan B. If that day you're not doing well, certainly, thinking about a plan B, there's always a different way that you can move that's gentle, less fatiguing. Training modes, really a variety is best. Resistance training, for strengthening, and flexibility, stretching, and trying to get your heart rate up a little bit, balance training, and then don't forget about some breathing exercises, diaphragmatic breathing, core sort of strength training. So what is the evidence out there related to strength training? Yeah, strength training does improve strength. What's unclear is how much strength training impacts gait, or people's ability to walk. The suggestion from this article was that people really need to think about how they're exercising, and whether it's specific to the muscles for walking, is it specific to the positions of walking, or positions, and it could be your position in seated. Thinking about, like, if your goal is to increase your posture, improve your posture, improve your ability to reach, then you might want to target certain muscles and positions a little differently. But since it's very task specific, a lot of the impacts that exercise have. And they also recommended considering dosing beyond the minimum intensities. Certainly talk that over with your providers, your experienced clinicians with MS. Why does exercise help? So the short answer is it improves your endurance, strength, flexibility, balance. But we're really kind of diving into, like, what is specifically the cellular or the physiological thing that's happening with exercise. There is actually a little bit of research looking at MS and how aerobic exercise can improve neuroplasticity. So neuroplasticity is something that we want to promote. We want to be able to promote the nervous system to be able to adapt to any lesions or to be resilient to any sort of relapses. So getting your heart rate up. In this one study, they that we need to do more research, but in this one study, they did show that that people, especially on their stronger side, so that part of their brain was a little more likely to have those neuroplastic readiness. They looked at inhibition as well as excitability of the brain through this TMS system, and it's getting a little beyond my abilities here for basic physiology, but certainly some exciting implications there. So also looking at, Dr. Burdett alluded to the mitochondria and the role of the energy production of our cells and how that can be improved with exercise. And in particular, there's a study that looked at robotic assisted walking and how that people often still have similar mitochondrial improvements or energy production improvements by using that assisted gait device. So that's again another option and exciting potential for the future. And we are, as a physical therapist, I'm very interested in walking. Walking is an important part of determining the severity of the illness, the impact on not only the distance people can walk, but also gait speed and step length. Seems to be related to, at least in early to moderate disease, the severity of the illness. Certainly one of the more noticeable changes in walking that people first notice with the disease is that ability to pick their foot up, or sometimes the inability to pick the foot up. That foot drop is often one of the first things that people notice. So really I want to, that's the exercise part, and that's really important. But I also want to talk about options that are currently in practice related to technology, and what might be in the possible future. And this is really not a comprehensive list, but we got, I only have, 30 minutes here or so, or less. I'll try to get us back on time. So there is technology to improve assessment. So that's going to be maybe some remote monitoring. And then there's mechanical assistance, electrical stimulation, use of virtual reality, and then just providing a safe environment for people to practice, because that's really how neuroplasticity happens, is they practice and fail, and then they learn and practice again. All right, so these are some examples of what I call activity monitoring wearables. So a lot of people these days, this has really probably had the biggest impact on my practice over the past 10 to 15 years. A lot of people these days have their Apple Watches that they bring to me, and they show, oh, this is how many steps per day I've been doing. And it's really been wonderful to see how people do over time. And I would encourage people to actually monitor that and look at that, maybe even write it down. I did this many steps per week in 2022, and this is how many steps per week in 2023, and really track that over time. So the watches like Apple, Garmin, and Polar seem to be some of the best ones. There are others out there, Fitbit, that seem to be good too. We do have to at times take these in context. Sometimes they don't provide accurate information, but so that's why tracking over time can be really helpful, so you're at your own control, so to speak. One example is I had a gentleman that was doing a lot of arm activities for his job. Like he worked on an assembly line and he was moving his arm a lot, and that registered as a lot of steps for him. And that that's not exactly the activity that it was intended to monitor. Smartphones is another app. If you don't have a smartwatch, you could have a smartphone that can track steps per day as long as it's on you, and it's detecting those steps. It does have a little bit harder time detecting steps when walking at a slower speed. There's research-based wearables that are coming into clinical use. I think I'm gonna, just as a matter of time, I think I'm gonna move forward here. The next thing I wanted to show you guys was this. This is called a C-mill treadmill. This is a treadmill that's interactive. It's got sensors on the floor that can detect where your foot is, how much pressure you're putting on your foot. It's also got a screen to help you engage in an activity in a gaming sort of environment. And so you'll see a video here of this woman walking on a treadmill, but really trying to do it in a very dynamic way. We want walking to not just be very repetitive, but also being able to adapt gait. So here we go. She's walking, and then she starts seeing things on the floor, and she has to step on the soccer ball. And there's something coming, so she has to step over it or step around it. Yeah, so that's something we don't have at OHSU. I wish we had it. That's one of the things that might be down the road. But that's an exciting option that's coming out. It's a Switzerland-based company. I think it's a little more prevalent in Europe, but I'm thinking they seem to be marketing it more in the United States anyway. Let's see, I want to move on. Here's another video of the same treadmill. So what this person's doing is they're having to speed up to get to that, and once they get into the box, then it turns green and they have to slow down, and then it speeds up again, and here they are trying to speed up, and then they get into the box, and then they have to adapt their walking speed. So it's being able to not just walk one speed, but be able to speed up to get across the street if there's cars coming, or slowing down to match the speed of the person you're walking with, or just to slow down to be careful. All right, this is another video coming up here. This is on avoiding obstacles. So you'll see she has to kind of take some small steps and then take a big step, and it's really a dynamic sort of interactive gaming device. All right, and let's move on to the next option for technology. So this is maybe something familiar to a lot of people. This is an ankle-foot orthosis. So this is bracing. Bracing can be really helpful for energy conservation. Thinking about being able to walk a longer distance. These new materials that people are using, this is a carbon fiber material that you're seeing, provide a little bit of spring action, so which means they get a little extra energy out of that brace. It also provides the ability to lift the foot up and prevent falls. So like if your foot tends to drop and you're more likely to trip, if the brace can hold it in an upward position, so as you're stepping through, you're less likely to trip. The AFOs can vary in the stiffness, like this one on top is a little stiffer, so that means it's going to provide a little more support, which can be helpful for people that have some knee control buckling issues. The other brace down here is a little less supportive. So really talking it over with an orthotist, who's a person that would provide the bracing, or a physical therapist, or both would be ideal, to individualize it to your needs. These don't provide a lot of, these two that I have pictured don't have a lot of side-to-side support of your ankle. So if you have a tendency to turn your foot as you're stepping, it's not going to provide that sort of support. So you might need a little bit stronger or larger brace to have that medial lateral support. This is a couple devices related to electrical stimulation. So electrical stimulation with gait. There is a device that can stimulate the peroneal nerve, which I have a video here and I'll show you shortly. And it will help pick up the foot every time the person steps through. And then there's a biking device here. So this allows the muscles to be stimulated, like the thigh muscles, both the front and the back, or into the glutes or even the calves. And it stimulates the muscles to help promote bicycling. And the bicycling also has a motor to it, so it can assist if needed, or it reduces the assistance if a person is able to engage in a little more force. So there is small studies related to these things. The simulation device seems to, in a small study, that it did seem to produce some improvements in pain, improvements in fatigue, as well as even some cognitive improvements. Again, it's hard to tell how much improvement, or if this is properly powered research, probably not quite there yet. All right, so let's go to the video of the person walking. I hope everybody can see my video here. If not, ping me. This is a person with MS. So they have their walk aid, I'm sorry, not a walk aid, it's the BioNest. There is a walk aid device that does a very similar thing. This is a BioNest device, and you'll see how she has a hard time walking. Like in this video, it's off. The device is not turned on, and she'll have a pretty dramatic foot drop here. She has to really work really hard to drag that foot through. You can see that she's really struggling. We're gonna wear a shoe out. All right. So then in the next video, she's gonna turn on the device, and we're gonna see the difference in her walking. Let me enlarge it here. And this is a very good response. Like you don't always see this great of response in people with MS, but where you don't see good responses is when people have a lot of calf tightness or spasticity. That calf tightness or spasticity can prevent the foot from coming up properly. Sometimes the electrical device actually turns the foot a little bit, and that's not good. We don't want it to rotate it, because then you can't get your foot down flat. Some people have a hard time with the amount of stimulation that it takes. Also, it can have a hard time triggering if you have a hard time bending the knee. Like if you can't bend the knee to trigger the device, then let's see. I'm going to go on to are we back to my slideshow, I hope? If not, again, ping me and let me know. So we are back. We are looking at the supported systems now. This is changing gears out of the electrical stimulation to a harness system. So a harness system is the track is above people, and there's actually sensors in that tracking system to know if a person is moving. So it'll follow the person, and they're attached to a rope and a harness, and then that can provide some support or can provide no support. You can set it at 20 pounds of lifting, and then it will stay at that 20 pounds of lifting. Whether you're stepping onto a box or bending down, it adjusts. It stays right at that 20 pounds of lifting. So it just makes you a little lighter. Or you can just leave it in safety mode where it provides no lift, but if you happen to fall, it actually will catch you from hitting the ground. We don't have this at OHSU, but I've been in one of these devices. And if you do fall, like I tried to fall, and it slowly lets you down to the ground. There's sensors in it that if it senses a really fast jerking movement, it'll stop you. So this device really is probably the favorite of the physical therapists that if you talk to, because it really allows people to practice safely, practice things that they normally don't feel very comfortable doing. Balancing and bending over and reaching and outside of their limits, and seeing how you can respond. Like, can you respond by stepping with your foot? Can you respond with the stronger foot? Can you respond with the weaker foot? Lots of different creative ways to practice movement. Moving on to some robotic technology. We have a rewalk device. This is something that is used mainly in the spinal cord injury population. It has a motor and a battery, and it is pretty heavy, but you can. It's got a motor, so it can help you move your foot. The idea of the rewalk device is that people can walk outside or over ground. It hasn't been used a lot in the MS population. I don't know of anybody at least in the Portland area, that has it for MS. The Locomat is something that we have at OHSU that is used quite frequently. And I'm going to show you a video of that. This is a robotic device. And this woman is walking and looking at herself as she's walking here. I'm going to go ahead and start it. She has the harness to help her lift up. You know, they can adjust how much you're lifting the person as they're walking. Again, you can have no lift, or you could do all of the weight, or halfway in between. And then you can see the therapist there is really encouraging her to step out. And these robotic device, you can adjust how much help it's giving in the stepping also. So they call it guidance force. So if you set it to 50%, it's only going to provide 50% of that swing phase, or that stepping forward in gait. And back to the slideshow, hopefully here. This video thing, I think is working, going back and forth here. All right, supported walking. We saw this woman in the video being supported, but we also have other ways to support people walking. There's this Alter G, which we have at our clinic in OHSU. It is a device that basically a person is in an air bubble. They put on these specialized shorts and they step inside this air bubble, and then it starts to inflate with air, and that inflation, or that pressure, is lifting him up to be able to walk or run. And it's a good device. I prefer the Locomat over this, because it can be a little warm. Like the heat from it can be a little warm, and so if people are heat sensitive, it might not be the best option. Another device that is recently come out, I haven't had to try this one, haven't had a chance to try this one yet. It's called the Restore Exosuit. Again, this is has a motor attached to the person's calf and foot, and it can help assist pushing off too, not just like a brace that would help pull the foot up, but it also actually help with push off. And so that push off during walking is so important for walking speed, and it can help reduce energy costs for walking, or walking more quickly. This is a really interesting, maybe down the road technology. This is a treadmill that you can walk various directions. You don't have to walk just forward. And we'll see in this video here that the person also has virtual reality goggles on. They can put people in environments where they feel like they're in a grocery store, or they can look around and really provide an interactive environment. Try to have people work in environments that maybe they don't normally feel comfortable in. And you can see there that she is turning, and there's all these little individual treadmills that will move with her, so it knows which way she's turning and which way her foot is going. Here he's got the virtual reality goggles on, and it's the treadmill just keeps the person towards the center of the device. So that's really interactive. The research related to virtual reality, let me go back here, the technology really, the research related to virtual reality is that often people have improved ability to do what we call dual task. They can often think about something else as they're walking. Like, so often people just really have to focus on what they're doing. So if we can open up their world to be able to walk with good quality, as well as being able to think about what they're doing, it can prevent falls, because often what happens when people are distracted is they can fall, so they're not as focused on their walking. So this is something that I like the idea. There's certainly ways we can, in regular rehab, standard conventional rehab, to do dual tasking or multitasking in a safe way. We don't want to decrease the quality of the movements before we add on that dual task. So that's a very good example of what I wanted to talk about here. I wanted to give a little plug to some research that I was involved in with Dr. Cameron at the VA and at OHSU. So there was a virtual delivery of rehabilitation, and we It was a very task-specific training that we did during COVID. It was something that we initially wanted to do in person in the clinic, but then during COVID, that changed everything. We ended up changing it to virtual, which actually turned out to be a benefit, I thought. Many of the patients were satisfied with having that virtual delivery. They wanted to be able to work on things in their home. And that's what the quotes here, they found it most useful for problem solving what they were doing in the house. Within the context of their home, they could get in the kitchen and how are they bending down to get to things. They could sit in their kitchen chair or they could sit in a living room chair, and how are they supposed to do that properly? If you think about just plopping down in a chair, you're not really using your muscles. So if we can practice throughout the day, slowly sitting down in that chair, that's going to build strength. So that task-specific way to build into your daily routine is a wonderful way to prevent impairments of down the road. There is some research recently coming out, again, small numbers. A lot of these technology research do have small numbers of people and very preliminary results. So normally when we do strengthening, we try to, the American College of Sports Medicine recommends about 65% of your maximum weight when you're doing strengthening, but that can be really hard to do. It can be very fatiguing. Like, we don't want people to be just doing 1 or 2 repetitions and being exhausted. We want people to be doing 10, 15, even 20 repetitions of their exercise so that they're not getting that exhaustion. And so trying to do 65% of your maximum weight can be exhausting. So what we're doing here, or what they're doing in the research, is that they're doing some light strengthening, but they're doing it under a blood flow restricted situation. They're actually reducing the blood flow about 40 to 80%, so not totally occluding, but it's producing a stress on the muscle. And that's what exercise often does, is it produces stresses on muscle, and that muscle can then respond by growing stronger. And so the preliminary work has been mainly looking at, is this safe? There's certainly certain situations that you wouldn't want to do this in, like if you do get blood clots, or even if you have like cardiovascular disease where your arteries might be weakened. That might be something you might not want to do this. But so you wouldn't want to jump in and do this without talking to your doctor or talking to your physical therapist. All right. So some great, exciting things out there happening as far as technology. Some of the realities of implementing this technology, clear evidence, which I've spoken to several times, looking at it long term, like looking at that BioNest with the electrical stimulation. It certainly does show some improvements in walking short term, but what are the long-term impacts versus not having that device? The ability of patients to adhere to like the research protocols. Often these protocols are a little unrealistic as far as doing 4 times a week in the rehab or research clinic, 3 to 4 times a week for 40 minutes. As an example, is that realistic for a lot of people? And then, do people have access to this technology? This is we have a number of things at OHSU, and we're lucky with that. But can people still get into the clinic to do that? It's really hard from a insurance reimbursement perspective to do that. We have provided people with a private pay what we call private pay program for using some of these devices, so they can continue to use it for months or even years. That private pay does cost, though. It's like going to a personal trainer, basically, is the cost. If you go to a personal trainer, it costs money, and so having that as an option. You might not have it locally, but certainly you can ask around at your therapist or your doctor's office. Having skilled providers, having people that know how to use this equipment and can physical therapists tend to be people oriented, meaning they maybe shy away a little bit from technology. So having somebody that can be both good bedside manner as well as being able to have awareness of technology is a skill. And I think we always blame a little bit on COVID-19, and I'll do that here. But maybe this will be the last time I do it. I hope so. The bottom line is I want people to move and have fun. Like, maybe I should have some self-compassion too in there as after our recent talk here. But I think like what she was saying, Dr. Young, it really is what I'm trying to say here too, is like if you're not engaged in movement and you're dreading it, you're not going to want to do it. So yeah, have a plan B and have fun. And that's all I have. So I'm going to go ahead and stop. Again, feel free to throw some things in the chat and answer questions. I'll answer questions at the Q&A later. And I'm hoping I got us back on time.
Yes, Jeff, thank you so much. That was perfectly on time. So thank you so much for being mindful of that. And also thank you for a very nice review. And I think the audience will really like, hopefully they have liked what you have taught them. And then they can ask many questions during the Q&A panel, so they can keep sending the questions to Dawn. So with that, I think I'm going to move on, and we'll introduce our next speaker, Dr. Carolina Garcia. She is our current MS and Neuroimmunology Fellow, finishing her first year with us. And Dr. Garcia, she did her medical schooling from College of Osteopathic Medicine in Fort Worth, Texas. Did her residency from Dartmouth Hitchcock Medical Center in Lebanon, New Hampshire, and started her fellowship last year with us, and will be doing the second year with us also. And her research interests are primarily looking into the neuroimaging as disease marker, as well as how we can have diversity and equity in MS care. So very glad to have Dr. Garcia with us speaking, and she will be talking to us about the treatment updates in multiple sclerosis. So Dr. Garcia, please welcome.
Hi, good morning, everyone. Thank you for having me. First and foremost, I hope everyone can hear me okay. I was having some technical difficulties this morning. Thank you, Dr. Yadav, for that introduction. And yes, so I am a MS fellow here at OHSU, and today I will, hello? Okay. So today I will be talking about treatment updates in multiple sclerosis. So as a fellow, I have no disclaimers to make at this point. I will just say that for the purposes of education, I will be using generic as well as some of the brand names associated with some of the medications that we'll talk about today. Next slide. So this is a brief overview of how the rest of your next 25 minutes should go. We'll delve into kind of the evolution of disease-modifying therapies. I'll try to my best to provide a very brief review of disease-modifying therapies. I think going through every single one would obviously extend beyond the scope of today's discussion, but also delve into a little bit of the therapies that are on the horizon in terms of MS care. Next slide. So let's begin by talking about disease-modifying therapy. Next slide. So as you can see, as much as we have also made advances in terms of the diagnosis of MS and the management of MS, there's also this treatment landscape that has significantly or astoundingly evolved over the last 30 years. We are very fortunate. I always tell our patients to live in a time where we do have ample therapies to offer you for your review and of course for your selection depending on specific case scenarios. Next slide. But when it comes to choosing the appropriate disease-modifying therapy for a patient, there's obviously a lot of things that we have to take into consideration. And the first and foremost, we always try to offer patient-centered care, and so we look at those patient-related factors that may influence our joint decision. And that at the top of that list is, patient preferences, what their risk tolerance is, what other medical conditions they have that we should be aware of when selecting a specific therapy. And for females of a reproductive age, what are their family plans from that standpoint. Of course, we can't ignore the fact that, we also have to look at what stage and what the course of their MS history has been, and what therapies could offer the most efficacy, along with a safety, and again, for their comorbidities and the reproductive status. Are there any prognostic factors related to the disease that may also influence our decisions? And as well as we have to acknowledge system-related factors, because these medications obviously come at a price. And so having insurance coverage and access to services is very important to help not only with successful treatment, but also adherence. And taking all of these factors into consideration, we have to look at adherence, GCV positivity, malignancy risk, and so on and so forth, as factors influencing or helping us direct which disease-modifying therapies we should begin with. But we also have to look at those that would influence us to defer treatment, looking at the activity of the disease, again, with females of reproductive age, what their pregnancy and planning status is, breastfeeding, etc. Next slide. And once, we look at a patient's history and their clinical course, and the question that is often posed to us is how we should approach treatment. Do we start off with agents that offer perhaps a lower efficacy level, but while mitigating the potential toxicity that may come from those potential therapies? Or do we believe that, depending on their clinical course, should we go ahead and start at the highest efficacy medication that may potentially present a higher toxicity warning to a patient? And there's really no set guidelines as to how to do this. It does vary from case to case, but currently there are 2 ongoing studies that kind of look at how these therapies are executed in the field. Deliver MS, for example, looks at determining the effectiveness of early intensive versus escalation approaches for the treatment of relapsing remitting MS. This particular study seeks to answer the important question: does early treatment with a highly efficacious or effective DMT improve the prognosis of people with MS? Versus the Treat MS trial, the traditional versus early aggressive therapy for MS, is a pragmatic randomized controlled trial that has 2 primary aims. The first being to evaluate jointly and independently among patients deemed at higher risk versus lower risk for disability accumulation, whether an early aggressive therapy approach versus a more traditional first-line therapy approach influences the intermediate risk of disability. And then the second aim is to evaluate if among patients deemed at a lower risk for disability who start on a first-line MS therapy but experience breakthrough disease, for example, or those who have to switch from a higher efficacy versus a new first-line therapy, have different intermediate term risk of disability. Next slide. But ultimately, the goals of disease-modifying therapy stay relatively the same. We always seek to improve the clinical course and outcome of MS, and this comes about trying to, of course, decrease the relapse rate, the development of new MRI lesions, decreasing as much as possible that long-term disability that's often associated with untreated or undertreated MS, and delay the onset of that more progressive phase. And then again, always patient-centered care, benefit, mitigating how much benefit or what benefit to the patient may come from early treatment in order to impact that long-term outcome. Next slide. So when we talk about first-line therapies, the way we often approach it with our our patients is to begin with those kind of earlier therapies that we had available. And first and foremost are the injectables. Next slide. So the first-line therapies, or we often refer to as the interferons, brand names range from Avonex to Betaseron to Xdivia. They were initially approved in the early 1990s. Dosing varies between either a weekly dosing to 2 or up to 3 times a week, whether it's a subcutaneous or intramuscular injection. Most of these were approved for the treatment of relapsing multiple sclerosis. And again, for the purposes of today's talk, I'll try not to take up much time going through each and every single slide, but overall we could see that early on these particular agents did demonstrate to a certain extent a decrease in the risk of annual relapse rate and disability progression. Next slide. So again, briefly reviewing some of them, the interferons have been initially approved for the relapsing remitting MS subtype. They range between a subcutaneous intramuscular injection with weekly range frequency doses. The most commonly adverse effects reported tend to be flu-like symptoms that often develop a few hours after the injection site and usually self-resolve. Patients have been reported to develop neutralizing antibodies against these particular type of disease-modifying therapies, along with mixed data as to the worsening or exacerbation of underlying depression. Like any disease-modifying therapy, there are at times associated safety monitoring labs. Oftentimes, while on interferons, a provider may elect to check a complete blood cell count and liver enzymes while a patient is on this therapy. Next slide. Glatiramer acetate was first studied in a phase 3 clinical trial in 1995. It was measured against a placebo study during a 2-year duration period. And ultimately, it was found to have about a 29% decrease in the annual relapse, or I apologize, relative risk of relapse with glatiramer acetate versus placebo. However, no significant effect on disability progression was observed at that time. Since its approval in 1996 for the treatment of relapsing MS, it has allowed us to collect at least over 20 years of safety data, during which very rare serious adverse effects have been observed. And given the relatively safe profile associated with this medication, there has not been any specific monitoring needed or recommended, but again, that does vary from case to case. Next slide. Okay, and then as again, reflecting back on that initial timeline, we've obviously evolved from the injectables, and early on we were able to transition patients from those type of therapies to oral therapies. Next slide. And among these, we have the sphingosine 1P modulators, most commonly fingolimod, siponimod, ozanimod, and ponesimod. Most of these have been approved for the treatment of relapsing MS at their respective time frames. Notably, fingolimod has also been approved for the treatment of pediatric MS in 2018, as well as siponimod being approved for the treatment of secondary progressive MS. Now, how do these specific therapies work? Well, our white blood cells navigate our body through what is called the lymph node system. And these particular agents work to sequester these lymphocytes and lymph nodes by inhibiting their kind of egress. S1P receptors are necessary for lymphocytes, for example, to migrate from the lymph nodes. So in essence, these agents work to inhibit that, as well as inhibiting the migration of dendritic cells to secondary lymphoid organs. Next slide. And again, all of this is for you to read at your leisure, but fingolimod was first fingolimod was further assessed in the Freedoms trial back in 2010, where the study aimed to assess the efficacy, safety, and tolerability of 2 doses of oral fingolimod ranging from 0.5 milligrams daily to 1.25 milligrams compared to placebo in patients with relapsing MS. And briefly, at a 2-year follow-up, there was a decrease around 48 to 54% in the relapse rate with fingolimod compared to placebo. There was about a 30% decrease in disability progression, although no additional benefit was observed from the 1.25 milligram dose compared to the 0.5 milligram dose. Again, this is an oral therapy that is taken daily, and in terms of its frequency and safety monitoring, most providers would elect to closely monitor a a complete blood cell count, your liver enzymes, as well as the risk of antibodies to the varicella zoster virus. Notably for this particular agent, there was a risk of bradycardia observed early on, and cardiac monitoring was often recommended for the first dose as needed. It does carry the risk or concern for macular edema, so oftentimes there is the recommendation for an ophthalmology evaluation at baseline, as well as about 3 to 6 months after initiating this therapy. Unlike other disease-modifying therapies, fingolimod can also be accompanied with a black box warning about withdrawal rebound relapses should this medication be discontinued. But again, that often should be discussed between a provider and a patient depending on the situation. Next slide. Siponimod was the first FDA-approved drug for the treatment of secondary progressive MS. It does come with a dose titration schedule depending on the CYP2C9 genotype. In the EXPAND trial, they did find that siponimod administered at 2 milligrams per day did reduce active brain lesion counts, as well as reduce the relapse rate for about 2/3 of our patients. No significant difference was observed in time to 3 months confirmed with worsening of a greater than 25% of the time 25-foot walk. So it's just another within the class of those agents. Next slide. Ozanimod, unlike its no first dose observation required. However, there have been some interactions observed between the medication and particularly tyrosine content food. So there is that recommendation to observe the taking of this medication with other medications such as SSRIs, SNRIs, opioids, and TCAs, as well as again with the caution to avoid foods with high tyramine content. Next slide. Ponesimod is one of the most latest medications of this type to be approved for the treatment of relapsing MS. It was observed to have a 30% reduction in the annualized relapse rate at 108 weeks. It was observed to reduce the number of inflammatory lesions on MRI by 56% compared to teriflunomide. Notable adverse effects to this medication were observed to be some liver enzymes abnormalities, hypertension, hepatobiliary disorders. So again, the safety lab monitoring recommendations that were observed in earlier slides would have to be discussed between a patient and provider. Next slide. The fumarates are also another class of oral disease-modifying therapies. The most common one that people are often familiar with is dimethylfumarate or tecfidera. Tecfidera. It was approved in December of 2014, but we also have cousin drugs of this therapy that include Vumerity and baferdam or monomethylfumarate. These have been approved for the treatment of relapsing MS as well as active secondary progressive MS. And these drugs work by kind of modulating the immune system, reducing the circulating B and T cells that we know play a role in the MS pathophysiology. But obviously come with, given their mechanism of action, the risk of lymphopenia. Next slide. This is an oral medication whose dosing frequency can include up to 2 times a day. In clinical studies, this was observed to reduce the relapse rate by about 40 to 50%. Depending on the agent selected, common Side effects include GI side effects or GI intolerance, as well as some flushing. Given the risk of lymphopenia, a provider may elect to monitor CBCs quite frequently, as well as liver enzymes, because of the risk of hepatotoxicity and lymphopenia observed with some of these agents. And of course, the risk of PML, which we will discuss momentarily when we talk about infusion therapies. It should be noted that most recently a threefold less risk of PML was found in fingolimod and then 100-fold less in natalizumab. Next slide. And so that brings us to our infusion therapies, which has quite revolutionized the way we treat our patients with MS, and particularly those that now present with a more aggressive disease. Next slide. And infusion therapies basically rely on the employment of monoclonal antibodies. And as we'll discuss in the subsequent slides, we'll talk about how these particular antibodies have been tailored in terms of their immunogenicity to improve patient outcomes in those with multiple sclerosis. Next slide. And so that brings us to natalizumab or Tysabri. This received FDA approval for the treatment of relapsing MS as well as active secondary progressive MS. It is a humanized monoclonal antibody that targets the cell adhesion molecule alpha integrin on the surface of white blood cells, and thereby blocking their cell migration through the blood-brain barrier. A phase 3 trial in which natalizumab was administered every 4 weeks versus placebo, it was found to have at least a 68% decrease in the annualized relapse rate over 2 years, as well as a 42% decrease in the disability progression. As an intravenous infusion, it does come with quite frequent dosing at every 4 weeks. This medication does carry a program, and this program would serve to inform prescribers and overall healthcare providers about the risk of PML associated with natalizumab with treatment duration and prior immunosuppressant use. Monitoring of the JC virus antibody should occur at the very least every 3 months with MRI brain surveillance, again at the discretion of the patient and provider. We should note that the anti-JC virus antibody itself should not be used for the diagnosis of PML. If at any point there is concern for PML development, then of consideration would be an LP with a JCV PCR with consideration for biopsy if CSF is negative, and of course with MRI surveillance if suggestive of PML. And according to the latest literature that I could at least review as of February of 2023, there have been approximately 900 confirmed PML cases in patients exposed to natalizumab. Next slide. Lemtrada or alemtuzumab is another antibody-dependent cell-mediated lysis that following the binding of CD52 antigen to present on B and T cells, it was FDA approved for the treatment of relapsing and active secondary progressive MS. In the CARE-MS1 and CARE-MS2 trial, it was observed to have a reduction in the relapse rate by anywhere from 49.4 to 54.9% versus interferon beta, with a reduced in the 6-month sustained disability worsening by 43%. Again, this is an intravenous infusion that is administered in 2 courses, 1 year apart. The first course being about 12 milligrams IV per day for approximately 5 days, followed by a second course a year later with the same dose of 12 milligrams IV for about 3 days. There is a screening and safety program associated with alemtuzumab with subsequent monitoring with including a CBC and a UA, again, with the provider's discretion. It should be mentioned that at least one new case of ITP in the CARE-MS1 extension trial, as well as 10 new cases of ITP were reported during the CARE-2 MS care MS2 extension trial. Thyroid disorders peaked in both studies around year 3 and declined subsequently afterwards in both studies. And among the new malignancies noted in the extension phase, melanoma was one of it, hence the recommendation for at least an annual skin exam. Lymphopenia can also be observed with the administration of alemtuzumab, so monitoring with CBC could also be a consideration. Next slide. So now we start getting to kind of the nitty-gritty as to the pathophysiology of MS as much as we can, of course, discuss in today's talk. MS was previously thought to be largely a T-cell mediated disease, but now we know that MS relapses are thought to involve at least bidirectional interactions between several immune cell types, including B cells, both in the periphery and the CNS. And the investigation, therefore, of targeting B cells for the treatment of MS was based on the recognition that these are abnormally produced antibodies in patients with MS. And this can be manifested during, for example, the diagnostic workup by the increase in IgG synthesis rates, the CSF-restricted oligoclonal bands that are often identified in the diagnostic workup. Next slide. So but the role of B cells are often involved, or they involve more than simply antibody production. B cells alone can act as antigen-presenting cells to T cells and promote that T cell activation and proliferation. They can interact with antigen-presenting cells to influence antigen trafficking and also be more involved in the production of cytokines and chemokines that contribute to oligodendrocyte and neuronal damage. Next slide. So taking that into consideration with MS pathophysiology, we know that, CD20 B cells do play an active role in active relapsing MS and to an extent progressive MS, and also contribute to that chronic inflammation and demyelination and neurodegeneration, often irrespective of relapses that are also observed. Next slide. And so that, led to the investigation of B cell therapies and how B cell depletion and repopulation often affect a patient's disease course in response to therapy. The infusion of anti-CD20 monoclonal antibodies, CD20, which of course is present on the surface of cell lineage in pre-B cells to naive and memory B cells, often promotes the depletion of these B cells within hours, I apologize. Depletion has a nadir about around 8 weeks and can be sustained for several weeks to months. However, when repopulation starts, it can start in the bone marrow and spleen, followed by the blood. B cell counts usually determined by CD19 because it is less prone to potential interferences in the presence of anti-CD20s, and then overlaps with the CD20 during B cell differentiation. Next slide. And so for the next couple of slides, we will focus on the CD20 monoclonal antibody therapies for the treatment of MS. Next slide. And ocrelizumab is one that was quite, again, revolutionary, primarily in the treatment of primary progressive MS, as it was the first FDA-approved agent for that specific MS type. It is a second-generation anti-CD20 monoclonal antibody whose function is to deplete for the depletion of immature B cells. It obviously went quite an extensive clinical study, but in summary, the OPERA-1 and OPERA-2 studies, ocrelizumab was found to have a decreased annual relapse rate by about 46 to 47% versus its counterpart interferon. And then in the pre-specified pool analysis, it showed a lower risk of disability progression with ocrelizumab. It is an intravenous infusion with the dosing dose being about 600 milligrams that is split in the first, or what we call the induction dose, on day 1 and day 14, and then followed by one infusion every 6 months. It does, because of the degrees of its efficacy or potency, there is several screening and safety monitoring labs that are recommended. Among those, like many of its predecessors, CBCs, liver functions, hepatitis B serology, as well as VCV and serum immunoglobulins, which should be continued about every 6 months throughout the duration of therapy. Next slide. Ofatumumab or Kesimpta was approved in 2020, also for the treatment of relapsing MS and active MS. It is a humanized anti-CD20 monoclonal antibody that again seeks to deplete immature B cells. In clinical studies, when compared to teriflunomide, it was observed to have a relative risk reduction of 50.5 and 58.5% respectively. It is a sub-Q injection, so even though we do consider it is a B-cell therapy, it is not an infusion, and the sub-Q injection is administered monthly. And like its previous, the previous B-cell therapies mentioned, there is an according safety or surveillance lab monitoring, along with, of course, imaging monitoring that is recommended usually around the 6-month mark. Next slide. And that brings me to obinutuzumab, which is the latest B-cell therapy to have been approved as recently as last year. Next slide. So anti-CD20 monoclonal antibodies have long been bioengineered to become more humanized, and in doing so, changing their mechanism of action and their impact on MS pathophysiology. Next slide. What sets obinutuzumab apart from its predecessors is that it has been glycoengineered to exclude certain sugar molecules that are normally present on those antibodies and thereby interfering with their functions. Removal of these insurance molecules enhances their ability for effector cells, resulting in B cell depletion even at low doses. Next slide. Obinutuzumab does have a different dosing and administration to its counterparts. It is an anti-CD20 therapy that is also administered at a twice yearly dosing schedule. The first dose is 150 milligrams with the infusion lasting around 4 hours, but every subsequent infusion after that, which does it occur at a higher dose of 450 milligram doses, has been observed to last only about an hour. Next slide. And in terms of the efficacy and safety of this particular drug, it was further examined in the ULTIMATE 1 and 2 trials. Next one. And these were phase 3 double-blind, double-dummy randomized active control trials in patients with relapsing MS meeting the 2010 McDonald criteria that had an EDSS of 0 to 5.5 at the time of screening. And I believe also other inclusion criteria included at least 2 relapses in the previous year, at least 1 gadolinium enhancing lesion, and MRI abnormalities consistent with MS. Exclusion criteria outlined in the study was the use of prior or previous disease-modifying therapies and the durations of washout periods. This study looked at the intervention of administering IV obinutuzumab at the doses previously outlined, as well as in comparison to an oral placebo and an oral teriflunomide of 14 milligrams daily and an IV placebo. The primary endpoints of both of these studies was to examine the annualized relapse rate and as well as the number of secondary gadolinium enhancing lesions. And this is just a representative visualization of that theory, of that study. I apologize. Overall, the mean total number of, in terms of its primary endpoint, I apologize, the annualized relapse rate at 96 weeks was 0.8 in obinutuzumab compared to the teriflunomide group versus 0.9 in obinutuzumab compared to 0.18 in the teriflunomide group in the ULTIMATE 2 study. The mean total number of gadolinium enhancing lesions was decreased in the obinutuzumab group, and the mean total number of new or enlarging lesions was also decreased, observed to have been decreased in the obinutuzumab group. And then in terms of its secondary endpoints, about 5.2% of the participants in the obinutuzumab group did have had a worsening disability at 12 weeks compared to the 5.9 participants in the teriflunomide group. And in terms of disease activity, the obinutuzumab group demonstrated around 44.6% of that group demonstrated needed or no evidence of disease activity compared to the 15% in the teriflunomide group. In terms of its safety, the most common adverse effects that occurred in at least 10% of those recipients were infusion-related reactions, headaches, nasopharyngitis, pyrexia, and nausea. Some infections were also observed, most of them respiratory tract related. And again, among those infusion-related reactions were anything from headaches to chills to, again, influenza-like symptoms. And these are some key points that from the studies that I just previously pointed out. And for the sake of time, I'll try to hurry up a bit. So what's next on the horizon for in terms of MS treatment? Well, within the last decades, we've seen powerful therapies being developed to control relapse activity in MS. All of these agents were primarily designed to systematically target the peripheral and immune system and to prevent or to prevent CNS infiltration of immune cells in this regard. But one of the most promising strategy that has been presented is the inhibition of the enzyme of Bruton's tyrosine kinase inhibitors. Next slide. And for the sake of time, these tyrosine kinases are located in different parts of cells. Some of them are transmembrane, some of them serve as receptors. And for the purposes of today's talk, the one that we are particularly interested in terms of MS care is BTK. Next slide. Why are these type of enzymes? Sorry, next slide. I think you might be going back. Can we advance?
You want me to go back a few slides here?
Forward.
Forward, yeah. So moving forward. Are we missing slides or?
Yes, can you jump to slide 45?
Okay. Oops.
Yes, that looks more familiar. Unless we are out of time, I'm not sure.
Dr. Garcia, I think we can wrap it up in like next couple
Okay.
minutes or so.
Sure. So I don't know if just it's on my end that my computer has frozen, but I think we're still lagging behind on some slides. But just tyrosine kinase functions are a novel class of DMT that target both the innate and the adaptive immune system, and which play essential players in innate immunity. So there are several studies, I don't know which slide the audience is looking at right now, that current clinical trials examining the role of BTKs in MS and how they may impact disease activity. There is also stem cell transplantation. As you know, stem cells have the ability to develop into different cell types, and their potential role in regenerative medicine, as well as their function to repair damaged tissues, of great interest in the MS field. Autologous hematopoietic stem cell transplant is particularly in the BEAT MS study, which I think OHSU is one of the participating sites, seeks to kind of compare that treatment approach to what we call the best available therapy in treatment with MS. And I know we are due for a research update in the next portion of today's talk. So I believe we have successfully enrolled one patient. Please feel free to correct me that, but I think it's also very another exciting avenue of care that merits further study. And I apologize for running out of time. I think, like I said, it's a very a very broad topic to cover, but I'm hoping that at least I was able to provide you with a little bit more knowledge about how your disease-modifying therapies work, and if not, what conversations you can elicit with your provider.
Thank you, Dr. Garcia. No, I know it's too much information in such a short time, so it's always a struggling. How do you finish so much information, which is good for all of us, like, good for the patient. We have so many more things happening. So thank you for a great overview. And I know we have a little bit of less time now, but it's okay. I think we will try to catch up because we have the exhibit and the break right after my talk. So I may just go a little longer and then we'll start the Q&A session right on time so that we finish on time. So I think that should be okay. But anyway, thanks again. Stay on because we have the Q&A session and we have a lot of questions from the audience. So it'll be great. Thanks. So can I get my slides here? Research updates in MS. So hello everyone again. I'm going to actually talk about the research that is happening at OHSU, by our researchers, our clinicians. So mostly I'm going to talk about the clinical research updates, even though we have a very robust basic science portfolio in MS and neuroimmunology as well. Next slide. These are my disclosures. Next. So as I mentioned previously, like at the beginning of the presentation today, that we have a very vibrant group of faculty. We have 9 of us actively working on not only clinical care, but also research. So I think the primary researchers here are myself, Dr. Spain, Dr. Willis-Croft, Dr. Cameron, and Dr. Silverman, and Dr. Holland is also joining us, looking at some very exciting MRI imaging and kind of newer novel technology in imaging. And then rest of our providers actually are helping with the kind of patient care, and like they also participate in the research as we need them to. Next slide. So just to give you an overview of when we talk about research, what actually do we do? I mean, I told you that we are going to do I'm going to explain the clinical research which is happening, but to work at a university is a privilege. And when we do any kind of research, we really strive for the best in the field, like what is cutting edge. And to really have that cutting edge research opportunities, you need to have a very robust center support as well as the university support or the facility support. So I'm just showing you here, because we have affiliation with the Veterans Affairs MS Center of Care, or MS Center of Excellence, sorry. And because of the university affiliation that we have with really pristine kind of resources, for example, like to have the access to Advanced Imaging Research Center. And this is a center which has allowed us to do imaging in humans or in patients using 7 Tesla MRIs. When I say 7 Tesla MRI, the routine imaging that happens for MS, like in clinical care, is 3 Tesla, or it used to be 1.5 Tesla, which are lower strength magnets. So we have the capacity. In fact, I myself have done, and we'll be sharing some of the results here today about the utility of 7 Tesla MRI. And there are a handful of centers in the country who have this capacity to do this kind of advanced imaging research in MS. In addition to that, I'm very proud also to have this very strong resource called Oregon Clinical Translation Research Institute, which actually is funded by NIH and has been very instrumental in a lot of the very basic research that the clinicians have started, including myself. And we are able to utilize the core such as the bioanalytical core at OHSU, which allows us to identify new novel molecules. Same thing is true for the Department of Physiology and Pharmacology, which also, as Dr. Baudet alluded to in his talk, like to discover novel treatment, novel molecules, you need to have these expert chemists or pharmacologists who help you design and help you come up with these new molecules. So they have been extremely instrumental in our progress into the clinical trial that we move on to. Having access to Night Cancer Institute has allowed us to take part in this highly reputed and kind of the transplant study, the stem cell transplant study that we are undertaking right now is only because of our collaboration with the Night Cancer Institute and the transplant group that we are able to do this kind of high-risk treatment option here. Then having access to exercise physiology lab, having access to the KCI Institute, and experts who have access, who are expert in like gut microbiome analysis or metabolite analysis. They are all going to keep our research capacity really robust and up to date. So it takes a team. I mean, my point is like it is a team's effort, what we do here and what we're able to give back to the community. Next. So just to give you an overview of the current clinical research portfolio at our center. So what you see here is the research that is being conducted is utilizing novel treatment, novel options such as lipoic acid, which is done in progressive MS by Dr. Spain. And this was a molecule which Dr. Baudet had started in the animals, and then like I did the initial human studies in MS, and then she took it on to studying the progressive MS, and it's showing very promising results, as I will allude to in my next slides. We're also looking into another antioxidant called MitoQ for fatigue improvement in MS. This study has been funded by the VA, which is actively enrolling right now. So anybody in the audience who wants to participate, who have a significant fatigue, they're welcome to connect with us to assess whether they'll be eligible for the study. Diet in MS, it's a topic of significant interest in our patient population. And from the time of Dr. Swank, when he first came up with his diet to where the diet research is, we have really made huge progress. And I think all of us have contributed, and I'm going to share some of the findings from our study that we recently completed. Dr. Woolliscroft, she's a faculty who just joined us in 2020 and has been funded by NIH for a very prestigious award. She's evaluating the effect of aerobic exercise on remyelination, mobility as well as remyelination potential of exercise in MS, and it's a very well-designed study, and I'll give you some more details later on. Dr. Silberman is looking into the role of kind of imaging, and also can we learn from the retinal vasculature about how the MS progresses, especially in MS patients who have vascular disease risk factors, and we'll talk about that as well. And Dr. Cameron has been looking into sort of from a physical therapy perspective, like using a multimodal walking aid program in MS. What can we learn from using like that kind of training device? Next slide. So the first slide here is about lipoic acid research at OHSU, which I think you've been hearing about quite a bit. We have talked about this in our publication. Dr. Spain has given multiple presentations, and very excited to have this research done here. As you can see here, this was a study which was published in 2017 and was a study looking at the supplement which is available over the counter called lipoic acid. The dose that we had tested was 1200 milligrams once a day in the morning. And this was a 2-year study which was done in progressive MS patients. And what you see here is the red line as well as the this blue line. So blue line is the rate of sort of brain atrophy progression in patients who did not receive the lipoic acid, versus the people who were getting lipoic acid with a 2-year period has very much slower rate of brain atrophy progression. So there was almost 67% difference between the two groups over the time in brain atrophy. And this is a study that we are actually, she is currently, next slide, please. So she is, so now she's trying to replicate the finding that were published in 2017 paper. And then also to study if lipoic acid, in addition to the brain volume changes that we saw, can it improve walking and improve fall in patients with progressive MS? So this study is primarily funded by the Department of Veterans Affairs, has 5 VA sites, also has 6 university sites, as well as 1 Canadian site, funded not only by the VA, but also by the National MS Society, as well as the Canadian MS Society. So they have completed their enrollment. And next slide, please. So this is where the current state of the study is. So they have 75 people who have already completed the study. And there are about 13 remaining subjects who will complete the study at the end of this year. So we are hoping that we will have the results from this study by beginning of next year, at least some prelim data from the study results by beginning or mid of the next year for sure. The baseline paper, which was describing the findings of the subjects when they entered the study, has been already accepted for publication. So that that data will be available, hopefully, pretty soon. And so I think, yeah, we are very excited about the results, what that will show, and whether the role of antioxidants will be defined further using this study is yet to be seen. One of the things that when we are studying these products is, or any over-the-counter product, is the risk. So in this study, while when we designed the study, there were no significant risk factor or risk or adverse events seen in the literature. But during the course of the study, we have recognized that there is a risk of a very rare kidney autoimmune condition in people who are taking lipoic acid. So that has allowed additional monitoring of the people who are taking lipoic acid. So anybody in the audience who's taking lipoic acid, they should be aware of this risk factor, and also make sure that you talk to your doctor, neurologist, or otherwise to monitor your kidney function, including blood tests and urine tests. So something to really keep in mind, and we'll be happy to give you more information in the Q&A session. Next slide. This is a study which I want to also talk about briefly about our experience with the low-fat diet study, which we did primarily looking for fatigue in MS. This is a team, as you can imagine, like any clinical trial requires a huge number of team members to be able to successfully conduct the study. Next. So this diet that we studied had, it's a low-fat diet. So the total calorie from fat not to exceed 20% of the total daily caloric intake, 20% fat, 20% protein, and 60% carb. So primarily carb is complex carb, and I'll show you the breakdown in the next slides. We did allow, while the study, while the diet is actually primarily plant-based, it was, subjects could take lean sources of animal protein, such as chicken, fish, egg white. We did not allow people to take dairy products, and this study was a small study, like 16-week study. So I think it was okay to try this kind of like an elimination type of diet, but typically we do not recommend elimination diet. But I'm going to share the results with you. Next slide. So the study, as I said, was 16 weeks, and we had several assessments at the baseline and compared that with the 16-week outcome as well as throughout the study. The average, so the number of participants who took part in the study was 39, with 20 people randomized to the low-fat diet and the 19 people in the control arm. Average age of this population was 50. Average disease duration was 17 years, about 12.6 years from the time of diagnosis. 82% were females in the study. The BMI 31.75 is considered obese. So you can say like majority, or I would say like the mean population was obese in this study. EDSS of 3.78 reflects mild to moderate range of disability. So people were slightly more disabled compared to EDSS of 2 or 2.5, which is lower disability level. Majority of people had 92% people had relapsing remitting disease type, and majority were on disease modifying therapy. As you see here, 80% were on disease modifying therapy, with majority being either the oral therapies or the B-cell therapies. Next. So what we found here is, so the blue line is the people who are in the waitlist group, and the red line is the people who are in the diet group. The people started with the total fatigue score closer to 50 or 52. And as the study went by in the 16-week duration, you see significant drop in the fatigue levels in the diet group, whereas the the control group or the waitlist group did not really have as much of decline in the fatigue. And what you see here on the right side is the change in the diet composition. So we assessed the change, whether the subjects were actually doing the diet change, and how did we quantify? So we quantified that by using a very very specific outcome measure called 24-hour diet recall. This was done by a registered dietitian, and she would capture what people were eating, and then we calculated that from the diet, what was the change, what was the fat composition, what was the carb composition, what was the protein composition. What you see here is, as was recommended by the study, people were able to, in the diet group, able to decrease the fat closer to 24% compared to where they were at baseline, which was 40% of their fat, of the calorie daily was coming from the fats. Next slide. And this figure just shows you a change in the fat composition. So percentage calorie at baseline was 39% coming from fat, which went down to 29% on an average at week 16. And then on the waitlist group, there was no change. And the diet group also found significant change in the dietary fiber intake or increase, as well as carb increase, and the protein remains stable. Next. The next slide is about the study which we are looking for, MitoQ, which is a compound similar to CoQ10 or coenzyme Q10. Many of you may have seen the CoQ10 being available over the counter. So what we are testing is whether CoQ10 or MitoQ, CoQ10 actually was shown to show some promise in fatigue and depression in a small study. So because MitoQ is considered to be a stronger molecule than CoQ10 in affecting the mitochondrial function, our goal is to see whether we can see similar results in this study. And again, the target is fatigue in MS. It is a double-blind placebo-controlled trial, and it's a 12-week intervention actively enrolling right now. And in addition to the fatigue, we will be looking at other factors as well, like quality of life, depression, as well as some blood tests to see whether these compounds can change the immunology or the oxidative biomarker, oxidative stress biomarker in any way. Next. So this is a slide that I mentioned briefly early on by Dr. Woolscroft. She's looking into exercise as a remyelination therapy in MS. It's a beautifully designed study funded by NIH as well as a few other sponsors. And looking at if the aerobic exercise done on a stationary bike, and the actually study provides a stationary bike to the participants, and whether it can promote remyelination as seen on the brain and spinal cord imaging. So this is, I think if any of you have taken part in the study, it would be great to share your experience. But in general, what I've heard from the preliminary results, that people have done extremely well, and they are really seeing improvement in kind of symptoms as well. But of course, we will wait for the final study to be completed to get the final results. Next slide. And I think this is the same thing, like, if you want to take part, they're still looking for subjects. So feel free to reach out to mscycle@ohsu.edu if you want to take part in the study. Next. This slide I just want to share because there's a lot of buzz about what the role vascular disease risk factors can play in MS. And there's recent, in the last, I would say, 15 years or so, there has been increasing data that presence of other diseases such as hypercholesterolemia, hyperlipidemia, hypertension, heart disease, obesity, all of them are not good for MS patients because all of these diseases individually have sort of detrimental effect on the brain and the central nervous system health. So there is data that shows, and this is from a slide publication by Dr. Murray, Ruth Ann Murray, in 2010, that showed that MS people who have vascular disease, they tend to have faster disability, almost 6 years sooner disability than people who are otherwise healthy from the vascular comorbidity perspective. Next slide. So we designed a study looking at sort of longitudinally whether people with MS who have vascular disease factors, is their brain function different from people who are healthy? So we did the 7-test MRI, which I mentioned to you, having the Advanced Imaging Research Center at OHSU allowed us to do this kind of very high quality research. And I think it's the first of a kind in the world that I know of, looking at, directly looking at the brain metabolism in MS patients and see whether it changes over time. So this was a 3-year-long study. We did MRIs annually, starting at baseline and 3 more. And then right now we have published the results from this baseline data. And that's what I'm going to share with you. And the rest of the analysis is underway, and hopefully we'll be publishing that by end of this year. Next. So what we found in this study, that we had 60 subjects we initially enrolled. The MRI was available for 52 people. The average age is 52 in the negative group, and people who have vascular risk, they are a little bit older. Majority of them are females, and the diseases that they had, majority of them had hyperlipidemia or obesity or hypertension. And majority were, or they were on disease modifying therapy. Next slide. What you see here is a difference between the two groups. 30 BMI is in the obese category. So people in the VDRF group were obese versus people who did not have the vascular disease had a normal BMI of 23.5. And waist circumference, thigh circumference, that all matches with what goes with BMI. And also the vascular disease group had a higher insulin level, higher cholesterol, higher triglyceride, and higher disability also at baseline. Next. And so what we were trying to do with these advanced MRI, the 70 MRI, is understand the role of mitochondria. And mitochondria is the seat of energy production. That's where the cells, each and every cell in the body has mitochondria, and it is the site where they produce this molecule called ATP, or adenosine triphosphate, which is the basic molecule that we require to function. The energy that we need to do anything, any action that we do is based upon the ATP function. So this is assessing the role, the kind of the ATP function in the brain. And what this graph shows you are the different spikes or different peaks that you see here are on an MR spectroscopy. So these are very advanced imaging, again, looking at the amount of ATP which is present in the brain tissue at a certain place where the imaging was done. This study was done several years ago and showed that the ATP in the brain in MS subjects is different from what we see in the healthy control or healthy subject versus MS. So if you look at just the ATP here, the healthy control have higher amount of ATP versus MS patients who have lesser amount of ATP or less energy. Next slide. So this is what we assessed in our study as well. And this blue bar is the people who are VDRF negative, meaning they do not really have the vascular risk, versus the orange bar is the MS people who have vascular disease. And so you can see here there is difference in the two groups, with people with vascular disease having lower ATP, meaning lower energy reserves in the brain tissue. We looked at specifically at the occiput, which is the back part of the brain, and both white matter and the gray matter of the brain. So this is what we are seeing so far, and we are as I said, we are looking at the analysis of the next set of data to see whether this holds true and how does it change with time. So we will keep you posted. Next. Dr. Silverman, she's doing a study looking at vascular disease, but she's looking at how does it change the blood vessels in the brain as well as in the eye. So she will be looking at the retinal vasculature, which is the back of her eye vasculature, and whether that could predict the sort of progression that we see in MS. So she is fully enrolled with her study, and then hopefully we'll have some results by the next year. Next. And Dr. Garcia mentioned briefly about the transplant. The first subject has undergone transplant as part of the study at OHSU. So we are just waiting cautiously how the person does over time. And this will be a longitudinal study, so we'll be following the subject for several years going forward. Next slide. Again, the research cannot be done without the wonderful staff that we have, the clinical research staff that we have here, and whether it's Emma, Allison, Karen, Thatovic, Sharon, Andrea, Kevin, Paro, all of them, they make our life so much easier. And, like, you know, research is not easy by any means. Clinical research definitely is not easy, and having their support, having such a wonderful team, it makes me very proud. Next. Basic science, I'll just touch base. We do not really have time to go into this today, but this just gives you overview of, like, you know, that basic science research at OHSU is very robust. Our scientists, whether it is looking at myelin, which is the covering of the neuronal cells, or whether looking at the neuronal itself or the cells which make the myelin, like oligodendrocyte, all of these, so we have the experts in these fields at OHSU. And, like, you know, Dr. Burdett has alluded to in his talk how some of the novel therapies that were developed at OHSU now have gone into the production, like they have gone into the industry, sort of, you know, manufacturing. They were all because of the work of these wonderful scientists. And we really, I think in the coming year, this field is going to grow more and more. And I think we hopefully will be able to target the progressive MS that has not been done before. Next slide. So again, without participation from all of you, research cannot happen, especially clinical research cannot really happen. So keep taking part. I mean, your participation encourages us, and then we can help, like, you know, help you. So all of this is, like, you know, always mutually, like, you know, we are benefiting each other in many, many ways. So feel free to, like, you know, always reach out to us anytime if you want to take part in the research here at OHSU. Next. So as I said, like, you know, support us. We are here to help and do our best in trying to find the best opportunities, best option therapies for our MS patients. And there's more to come always. Next. I think that's it. So thank you again for your attention. So I think we are taking a break. And Don, if you want to just come over and, like, you know, just give overview of what's coming.
Yes, so we're running a little bit behind, but we have a pretty long designated time for the Q&A panel. So what we're going to do is we're going to come back at 12:45 for the Q&A panel. And so but first we'll take a break for the next almost 25 minutes. And so if you need to go grab a snack, grab lunch, stretch, please do so. Also, we have wonderful exhibitors that are here, people from the National MS Society, GENENTECH, BRISTOL, SQUIBB, BIOGEN, and PONS, HELIUS Medical. So the exhibit links are in the YouTube description, and they're also in the exhibit email that you would have received. If you have any questions or any issues, please email and we can troubleshoot that. Go ahead and, like I said, I encourage you to visit, and then we'll plan on coming back at 12:45 for the Q&A speaker panel. And if you have any questions, next slide, please. Email. So if you have any questions for the speakers that presented today, just specific MS related questions, you have a great opportunity here with wonderful faculty to ask questions. You can email me, chris.ohsu.edu, and I will compile all the questions that we're receiving, and we will go through them and answer all your questions. So please give us an email, and please, if you can, put question in the heading or the subject so we can make sure to route those in the right direction. And we will go ahead and plan on seeing everyone at 12:45 when we return. Thank you.
Thank you, Dawn. So I think it's 12:45. If I can have everybody online, perfect. Welcome everybody. And we have lots of questions, so I think the audience was very engaging. So I think what I'm going to do is I'll sort of summarize the questions in in groups. So we'll start with maybe Jeff with the questions that people were asking about mobility. So one question was about hiking, that a person cannot really go hiking because he falls. So should he be the one to decide that? And if not already told, who should be the one who should be guiding a patient if they have fallen, or what should they be doing in terms of mobility? I think very important question actually, like who should decide, like what should they do? Jeff, do you want to, did you hear that?
Oh, yeah, I did. I thought,
I can't hear
you know, you wanted me to answer right now. Yeah.
I cannot hear you.
Oh, okay. I'm not sure why. I got my mute off.
Oh, I can hear you.
Can you hear me? Can you hear me now, BJ?
So,
Okay, I think everybody else can hear you.
Well, I'll go ahead and answer it then. So I would take an interdisciplinary approach, obviously.
Yes, go ahead. I can't hear you, but you go ahead.
Yeah, interdisciplinary approach I think would be very important. Falls can be very physical, like a foot drop can certainly be a tripping hazard. So thinking about what sort of device might help prevent that fall, whether it's a AFO or a walk aid or BIONES. But also thinking about a person's risk, and like there might be some work from social worker psychology that thinks about how they are processing risk and how they might think about mitigating that risk. Yeah.
I think I'm having trouble. Can somebody else speak just to see whether I can hear somebody else?
Can you hear me?
I think I'm having a problem on mine. Don't want to take the questions actually, because I do not want to delay this panel. Can you just, go through that?
Yes, let me pull them up. Okay, Jeff. So it sounds like you just answered one of the questions about mobility. Can you hear me? Everyone can hear me okay?
Yeah.
Okay. So besides besides swimming, what other pool exercises might be beneficial for MS patients?
Yeah. When thinking about the pool, one thing to think about is your person's heat sensitivity. If you are very sensitive to heat, you would want to be careful about going to a very warm pool. Certainly, I've had people that get into a warm pool and they exercise and they have a hard time getting out of the pool. So that's my first, cautionary tale. But it doesn't have to be swimming. You can certainly move in the pool more freely. You could do holding onto a noodle and doing some bicycling. You can hold on to the edge and do some leg kicks in different directions. Certainly if you don't feel confident, there are instructors out there that can help you guide you in providing those exercises. The physical therapist could do it outside the pool, or you could have somebody that could help you in the pool.
Another question is, have you ever recommended an AFO foot drop brace to patients?
Yeah, certainly that's common for people that have fatigue, as well as at risk for falling. It's certainly something that you could put on and take off. Like in certain situations, you don't have to use it all the time. Some people are a little hesitant to use a brace, but you could put it on if you know you can go for a long walk, and then take it off if you're walking around the house, as long as it's safe. Yeah, certainly you want to have a physical therapist or an orthotist help prescribe it, because there are different materials, different stiffness, different ways to support the foot based on your individual needs.
Thank you. And where would one acquire a AFO foot drop brace? And can it also prevent the foot from turning outward?
Yeah, so you could talk often if you want to go through insurance, the doctor has to prescribe it. And then you would actually go to an orthotist who's a brace specialist to get the brace. The physical therapist should be involved, though, to help make that decision because of issues that you just mentioned, that ankle instability where your foot does turn does require a different level of support in that side direction of your foot. It might need more contact around the outside of that ankle.
We're going to switch it up a little bit. Dr. Zhang, I have a question about MS damage to CNS. If MS causes damage to the central nervous system and a patient has quite a bit of damage, how does an MS person manage the stress cycle, especially in the case of needed flight or fight, if the CNS cannot initiate or determine what to do and how to react?
Good question. So I think that it's really hard for us to be able to objectively know how much involvement the autonomic nervous system has been impacted. Certainly MS can affect the autonomic nervous system, and we have testing available, but it may not kind of be able to give the whole picture. So I think that if you're able to, kind of go through your day without kind of major like changes in how you're feeling in terms of needing a major break. Generally, it sounds like the kind of sympathetic nervous system is working, at least somewhat. Again, really hard for us to be able to clinically tell you how much has been impacted with. So I guess I don't have a great answer for your question right now. Certainly, if there's more research that's coming out on this, then we can kind of talk about it further down the line.
Thank you. Just kind of along this similar lines, if the flight or fight system increases blood sugar, is that why blood sugars increase when in a situation like an ER visit?
Yeah, it can. Any sort of acute stress, whether it's in times of an infection or if somebody has had, something like a seizure, those are kind of the more common stressors that can make your blood sugar increase. And in the kind of diabetic control, there has been kind of reports of people who are experiencing a lot of psychological stress, who are having difficulty managing their blood pressure, or I'm sorry, blood glucose, blood sugar in a hospital setting.
And if you have belly fat, could that be the cortisol accumulating from long-term stress? And if so, what kinds of things can help reduce that other than diet and exercise?
Mm-hmm. So yes, long-term stress can kind of mess up your pathways of how much fat to store and how your appetite, how satisfied you are after eating. So it's all kind of not a simple linear pathway, but there are lots of different pathways involved, and certainly it can look or present as difficulty in managing weight or obesity. Diet and exercise, yes, it's definitely part of the equation. And, the stress reduction takes time. It's not that you are going to today feel like you are stress-free or you engage in some relaxation exercises. And then tomorrow you're going to see results or changes in your body. So I think really the biggest takeaway for me throughout all this learning is that if you want to see major changes, but they comes from small steps, and each small step leads to kind of more feeling more empowered to make another small step. And over time, yes, you may be able to see that your weight and kind of body shape can change with long-term kind of focus on a healthy lifestyle, including diet, exercise, and stress management and sleep.
And then how does a caregiver for a person with MS convince the person to be mindful of their disease when they're cognitively impaired and can't always interpret the stress they're under?
It's really, really hard. It's possible that if somebody has a lot of cognitive impairment, that it might be difficult to engage mindfulness in that prescribed way. I think that, you know, from having a child of my own who's a toddler and also having a lot of pediatric patients, I think there's benefit to what we call co-regulation, which is the fact that you, as their caregiver or who's interacting with them, if you are able to engage in some form of regulating your emotions, for example, deep breathing, that's a very simple way, then your calm actually is shared with the person around you, no matter what age and how cognitively aware they are. And that can be really beneficial. So, you know, they obviously need some caretaking, and this can be part of the help that you provide to the person you're caring for.
Now I'm going to go ahead and ask some general kind of questions. So whoever feels comfortable answering them is fine. So I have heard on various podcasts that we don't have the technology yet to see progressive MS. In other words, the patient keeps getting worsening disability, but the MRI doesn't show anything significant. Is that true?
Dr. Boria, do you want to take that?
You're muted. I think you're muted.
Yeah, I can't hear you either.
What was that? It's true that standard clinical MRI scans are very poor at picking up changes that would correlate with the progressive deterioration of the patient with progressive MS. Research scans, however, are much more capable of doing that by detecting changes in atrophy levels, particularly of thalamus and the cortex. There's a lot of research being done on developing biomarkers or ways of assessing the disease process that's driving progressive MS. So, but it is true that the clinical scans do not show much change in somebody who's clearly getting worse from progressive MS.
Dr. Boria, there's one more question actually that the audience wanted to ask is, what is the progress, or is there a progress in determining the cause of MS? I think, do you want to share some of your thoughts? The cause of MS, like, you know.
Well, so we know a lot about what causes particularly the early stages of MS in terms of what's going on in the brain, what's going on in the immune system. The thing that's unclear is why does someone develop MS? We know that they've got a sort of an angry immune system that's attacking the brain, but why is that? Genetic studies have revealed a large number of genes that increase the risk of developing MS, but there's clearly triggers in the environment. There's been a lot of interest, renewed interest in the potential role of the Epstein-Barr virus as a virus that can trigger MS in genetically susceptible individuals. There's active research both in trying to establish that connection and also in testing new therapies that are directed against EBV virus. So it's possible that EBV or some other viruses could trigger an autoimmune disease in genetically susceptible individuals. So I think we know actually quite a bit about the disease, much more so than we did say 40 years ago.
Now, do you want to take the next question? No, we can't hear you. You are.
I just did that now. The star in technology. So these questions, a couple of these questions are going to be for Dr. Garcia. How often do you need to monitor the screen and safety monitoring for each thing on OHSU?
So the way that I've been taught or trained is that obviously you get your screening labs before starting B-cell therapy like OHSU, and if there's no contraindications or any abnormality of those labs that would preclude you from starting OHSU, then thereafter every 6 months I typically meet with my patients, and then the safety monitoring labs are actually collected before the infusion.
One thing which I'll probably just add to this as well is can you guys hear me? During the COVID time, when we became aware of sort of the profound effect of B-cell therapies on infection, especially COVID complications, we started looking for markers like B-cell proteins such as immunoglobulin G, immunoglobulin M, and CD19 count, which is basically the B-cell floating around in the blood. So that can be tested as needed in patients if there's any concern of too much immune suppression or having too many infections. So I think that should be done. And there are patients, especially elderly population, where you may not need to suppress the immune system much more so. So you can use that to tailor the approach in some way, which I think has to be done in close supervision with the neurologist, not on your own. So it should be guided by the neurologist.
If I mute myself, does it go away? It's usually me.
Right, I think that should work.
Yeah.
If everybody can hear me, then I can probably keep going. So one question was, maybe Dennis, I think I'll ask you this one. So this is an Army veteran who has relapsing MS, and they have seen information on diet and exercise, and that can help with remyelination, and he wants to take holistic route instead of medication. And he was on Avonex in the past, and that caused a lot of side effects. So she does not want to go the infusion route. So I think basically seeking our opinion on medication versus other approaches, complementary approaches. What do we recommend right now? So do you want to share your thoughts?
Me?
Yeah, sure.
Well, there are some people with mild MS who can manage their condition with low-fat diet, exercise, stress reduction. In general, herbs and things like that haven't been shown to be particularly effective for any even symptoms of the MS. If one opts for that, you need to still see a neurologist on a regular basis and get at least an annual MRI scan because patients can start off with what looks like mild MS and it can become much more active. And if that's the case, I really encourage the patient to reconsider medications. Certainly, it sounds like the patient's only been on an injectable Avonex, which can cause a lot of side effects. And there are other, as I mentioned, there's 9 classes of medications, and we usually can find a medication that the patient tolerates well and is effective. So unless somebody has really mild MS, I really think they should work with a knowledgeable neurologist at finding a therapy that is acceptable to them and they can tolerate. and use the diet, exercise, stress reduction as an adjuvant, as an addition to the disease-modifying therapy.
Thank you. So, Dr. Garcia, question for you about, I think some of the questions about BTK drugs. When will they be available to patients? If you have any insight on that, we can also share our experience.
Yes, I think Dr. Yadav's experience would be more reliable than my answer, because at least in my literature review, I haven't seen anything at terms of a timeline as to when these will be freely available to patients. So, but I don't know.
So I think what I've heard from the pharma reps who are working on these drugs, the pharma companies, evobrutinib, which is the first one, which is I think going to be completing the trial. The results may be available by end of this year or next year. So from the time results from the phase 3 clinical trials, and phase 3 clinical trials are required for the FDA to approve the drug. So from the completion of the phase 3 trial, and if that shows positive results, to the FDA approval can take another several months, even if it's fast track. So I personally don't think anything will be available until next year in that BTK. And other drugs are sort of running parallel or just like 1 year plus minus kind of thing. So maybe definitely in 2 years or 3 years, assuming that the drugs show efficacy and no significant adverse event or adverse effect signal, we should see them on the market. I mean, the good thing about FDA is that even though drugs like Tisabri had the risk of PML, or Ocrevus had concern of, at least in the beginning, there was some concern of some adverse event, it does allow the drugs to come, but under special, or including Lemtrada, which has a significant side effect, but it does allow the drug to be available for people to use under very close monitoring. So I'm hoping that that's how these drugs will be available if we see any safety signal. But so far, I think at least the pharma is saying like they are looking, the experience is promising so far. So we'll see. All right, so the next question is, I think it was similar to Dr. Bordet, what you talked about, whether using no disease-modifying therapy and just following a diet protocol, a SWANG protocol in particular, could that be helpful? So I think what we are saying is very few patients actually who have very mild disease may do well without the disease-modifying therapy, but in general, if you have active disease, that's not necessarily the recommendation that we would make. Using diet approach, and right now, frankly, we do not know which one is the right diet to do. I mean, we have probably more promising results in the fatigue using a diet, but in terms of disease modifying effect, I'm not sure we really can show convincingly that that's the case. Hopefully it will be true. So again, I think work with your doctor, work with the neurologist and see what they recommend, and definitely guided, mutual decision that you guys make would be the best approach for you all. All right, so the next question is about, I think, Dr. Barrett, I'm going to ask you this one about the T-cell trial. So they would like to know more about the T-cell trial and result of the T-cell study that were done. So do you have any insight on that?
The TCR peptide?
The T-cell, yeah.
Well, unfortunately, the TCR peptide therapy, which I thought was very encouraging, was the patent for it was picked up by a company that did some early testing in people with MS, had some encouraging results, then ran out of funds. And about the same time, the patents ran out. So this is a therapy that fell victim to not having enough money to fully develop it, and having a patent on the approach expiring, and then it's almost impossible to get to raise money to do an appropriate trial. So at this point, there's nothing going on with TCR peptide. There is a trial, an interesting trial and perhaps Dr. Yadav could comment on this. That's testing the ability of T cells that are made in the laboratory from people's blood to eradicate EBV infected cells. And this is following up on the theory that EBV, Epstein-Barr virus, is actually not only inducing the disease, but driving it. And I think we're looking forward to seeing the results of that trial.
Yeah, I don't have any more information than when we met last time. So I think that study results I've not seen yet. The one which was specific to the T cells targeting the EBV antigen. So other questions are about, are many people finding insurance wanting them to use older drugs for which generics are available? And is there a growing trend for insurance plan not to allow copay assistance to count towards deductibles or max out? So basically the financial burden of the drugs for patients. I think I can probably just talk about that because we're dealing with that on a regular basis in our clinic. So yes, that is true. The drugs, many of the drugs, again, each insurance differs in what their preferred DMT would be. And many of the drugs have gone generic. So if the cost is an issue, they will basically tell us to prescribe those, or they will not approve it for the patients. In general, though, generic drugs are they're equivalent to the main drug or the primary drug when it when it's approved. So these are, even though they are generics, they're approved by the FDA to be used in that disease conditions. I think from that perspective, we are using generic drugs whenever the insurance is not covering the primary drug. And insurance issues are an ongoing challenge in our practice. Each year, people will change insurance, the coverage will change. So it becomes quite burdensome on us also, and of course for the patients also, about the financial assistance, whether they're going to get or not. And also it's just an ongoing struggle for all of us, unfortunately. So Dr. Baer, I'm going to ask you this question about benefit of aspirin or other NSAID in reducing inflammation in the brain. Is there any data on that?
I know of no evidence that aspirin or non-steroidal inflammatories have a beneficial effect on MS. Those drugs work on different pathways than are important to the inflammation that goes on in MS. And I wouldn't anticipate that they would have any beneficial effect. Interesting.
So there was a question. Yeah. So there was a question on lipoic acid, especially about the autoimmune kidney disease that we talked about. So the way we are handling that, so it's rare. So I mean, in the clinical trial, I think we had probably 4 thus far out of the kind of 200 patients or so. So it's hard to say what the real prevalence would be. But since we are seeing it in the trial context, the nephrologists or the kidney specialists that Dr. Spain has been working with, they're also looking at in their population of people who have had kind of undiagnosed kidney disease, if they were exposed to lipoic acid or not. So I think that data is being collected at this time. What we typically do recommend is, yes, stopping. So it's a reversible condition. Stopping the lipoic acid does reverse the autoimmune kidney disease. And usually at this time we are check if somebody's taking, let's say, 1200 milligram once a day. What we have found is initially we were recommending maybe every 3 months, but I think every 6 month checking is reasonable. So every 6 months you can get the urine test as well as the blood test for kidney function in particular. And in the urine also, it should be looking for microalbumin. So it's albumin, which is like one of the proteins which is filtered into the urine, should be checked for to gauge if there's any problem with the kidney. Don, do you see any other questions? Like, feel free to chime in, because I know people were typing in more questions as we were going through this. And there was a question about the stem cell transplant. Why does it stop at 55 and only for relapsing and remitting? And a person with primary progressive MS who's 63, they would like to be part of this kind of study. So I would just say a stem cell transplant is not an easy procedure. It can have quite a bit of toxicity, especially with the chemotherapy agent when it's given. You can have significant side effects. So, the older the person is, the more the chances of side effects. So I think typically that's why we don't really go for it. And the data which has been published thus far in progressive MS, especially with the transplant, in limited studies though, but they have not shown as much improvement in the progression of the MS versus relapsing people who are younger. So I think that's where our challenge is, that younger people are more capable of handling with the side effects, if, to the chemotherapy which is given. So I think it's more for safety reason that you do not want to harm the person who's getting the transplant related all the medication that you get. So I think that's the main reason. And plus also, questionable efficacy from the results thus far. So. Not anything else that you're seeing in the chat that we have not addressed thus far?
Yeah, let me look really quick.
Yeah, one question which I think I have not really addressed is the recommendations, the current recommendations for use of gadolinium contrast in annual MRIs. Dr. Zian, do you want to take that one? What is, how often do we recommend, or should we do it, and why should we not use it?
Yeah, so we know that even though we don't know the effects of this kind of deposition, but we know that there can, be deposition within the brain of the gadolinium contrast agent, which is why we've been more judicious about when to use gadolinium. So generally, certainly in the beginning, when we're trying to establish the diagnosis, and soon afterwards, after starting therapy, we would recommend including gadolinium in the MRI images. But the enhancement really kind of shows us if there's active disease activity, if there's active kind of breakdown of the blood-brain barrier. So after, your disease has been stabilized, especially on therapy, if you're not, having new symptoms or having new lesions, then really there's not a role in using gadolinium at that point, because, it really just shows if there's active disease activity. So if you're not even gaining new lesions and not having worsening symptoms, then, there's no need.
And there's a question about tyrosine, and I'm not aware of that myself. So I'm going to ask the panel here if anybody knows the answer to that. Isn't tyrosine a food protein that increases over time? It can be slowed by freezing meals. What is the research of this related to MS? So I'm not aware of that, but I think if the panel wants to chime in. So I'm sorry, so we do not really have a good answer for you. And then I think there's a question about depression related to MS exacerbation and then dysbiosis in the gut. Does it have connection to depression, and how is it related to MS? So, Maria, do you want to comment on that?
Yeah, I don't know the exact research behind the relationship of the gut microbiome and depression, but I know that there is gut microbiome research going on really in every single specialty, including psychiatry. I'm not surprised if there would be a relationship. It's just that right now, I think that all the research in the different fields are pretty preliminary still. That other than specific GI disorders where they've been using transplants of kind of fecal matter, I'm not aware of any other kind of active therapeutic, available right now.
Well, thanks, Maria. I think I'm not seeing any more questions here. So I think the audience, if you have more questions, feel free to send us now. Otherwise, we can wrap it up by having like a final thoughts from all the speakers. So Dawn, what do you think? Like, are we getting more questions? Otherwise, we can wrap it up in the next few minutes.
Yeah, I think we received all the questions that we had.
Okay.
Some of them overlapped.
Sure. Yeah. Sure. Thank you. So I think we can wrap it up. After like maybe all of our wonderful speakers here, if they want to just say few final words on the topics or any other topic like that our patients should be like aware of now. So
I'll take a
Dr. Baird, do you
moment
want
to say something. I really appreciate the panel here and all the great questions. I think it's been a great way to really think about all the different options that we have for MS, and so really been nicely complementary of each other. And just to go back to the very first question about hiking, certainly hiking sticks. I didn't mention that very simple thing, like if somebody's hiking and tripping, certainly hiking sticks could be a very easy solution to that. Yeah.
Dr. Garcia, do you want to say?
Okay, I'm hoping there's no static. But I just want to say thank you for the opportunity to be involved in the panel, and I certainly appreciate the audience's questions. I know that there was some sort of time thing during my presentation, but I hope that it was still worthwhile for the audience. Thank you.
Thank you. Dr. Barrett?
I'd like to point out that Dr. Garcia and Dr. Jiang are examples of the type of young investigators and physicians that are going into the MS field and are going to continue to make contributions to people's lives over the coming decades. I find that very reassuring because we need doctors like them taking care of people with MS.
I 100% echo you. Dr. Jiang?
Yeah, really grateful for having kind of OHSU and our patients here as kind of my new academic home, and that it's just been a wonderful environment. Being able to kind of pursue some of my interests in kind of the topics I've covered. So thank you so much for giving me this opportunity to grow and share.
Thanks. And I think I just want to say a final thank to everybody, each and every speaker here, and especially Dr. Boyer, because I know having you at the 40th anniversary or 40th year for center is really special for all of us. So thank you for being present today. And I think we will plan some get together for the patients also, hopefully in December. So we will be, I'm sure Dawn will be informing or kind of the audience in future. But I think I want to say thanks, a big thanks to Dawn for putting this program together, and also for our tech support. Without them, we can't really function, and also our sponsors. So this kind of program takes a lot of effort. So really appreciate each and everyone's contribution in a successful program today, as well as that we have been doing this for so many years now. So a big thank you to everyone. So Dawn, take it from here.
Yeah, so if you could go to the previous slide, please. So some of you had already asked if the program will be recorded, and it is going to be recorded. And the same link that you viewed the live program is going to be the same one you'll use to view the recording. And so you can access it. And I'll also be emailing the MS email list that we have as well. Pretty soon, within the next hour, you'll receive a survey from me just giving us feedback about the program. We use this information to be able to come up with topics that you guys want to have, and also to make the programs even better. So we appreciate your feedback that you'll give us. And then also, I've received a lot of emails already about the drawing. And so thanks to everyone who participated in visiting exhibitors and being part of that process and doing the drawing. And I will be pleased to announce the winners. I'll be contacting them directly on Tuesday. And like VJ said, thank you all, the speakers, the exhibitors, everyone for their participation in this program. Could not have done it without you all.
So I think we can wrap it up then. Thanks, everybody.